Hey, welcome, ladies and gentlemen. You can't see us, but we can see you. We have a full session, actually. It's on renal replacement therapy, and without further ado, we start. We couldn't do it better than with Claudio Ronco. He needs no introduction. He'll talk about diffusion, convection, adsorption, what's best. Claudio.
Thank you. Thank you very much. The question was rather challenging, as you know. So, why do we need mass separation in blood purification? Because we have the retention of several molecules, PAMPs, DAMs, enzyme inhibitors, and at the end of the story, these molecules accumulate in the blood. Then we need to mass separate because you see the retention molecule profile by proteomic assessment, an enormous amount of peaks of potentially toxic molecules. And these molecules indeed may have an impact on distant organ functions and affect also mortality. In the acute patients, we are very well aware that some of these molecules may affect the activity of monocytes, macrophages, and the activation of immune response with intermediate mediators that are also having effect on distant organs. Unfortunately, these molecules have a molecular weight in a range where it is rather difficult to provide mass separation by classic dialysis systems. We have recently provided the classification of uremic toxins and their role in kidney failure, published in JSON. And here you see the spectrum of inflammatory uremia retention molecules that may affect acute and chronic kidney disease patients. So we have somehow tried to map by the possibility of removing different molecules with different membranes and modalities, and this table is available on the JSON paper. What do we do? Basically, we do hemodialysis, hemofiltration, and hemoadsorption. So these are the three mechanisms that we are utilizing in our blood purification system. Now, the question is, what is best? Well, first of all, let me tell you that for small molecules, we can certainly provide excellent removal by diffusion, and this was demonstrated by the early experiments done with dialysis, although diffusion coefficient of small molecules may be affected by electrical charges or protein binding. So the gradient that governs diffusion may be affected. On the other hand, we use convection in order to remove larger molecules. But again, larger molecules are not only molecular weight defined, but also molecular radius because of the folding of the molecules. And this depends, of course, on the sieving capacity of membrane. And you can see that we can move from high flux to high cutoff to high retention or medium cutoff membrane characteristics. Then we have sorbents, which are characterized by typical adsorption isotherms and are described by specific curves that identify the optimal design of a cartridge. Now, looking at the more recent acquisition on adsorption, we know about interparticle, extraparticle, and intraparticle flow of the fluid phase, which is blood. That depends on several different variables and the design of possible cartridges. But certainly, today's art of hemoperfusion takes advantage of more biocompatible sorbents compared to the past. But of course, we need to demonstrate effectiveness and other characteristics. Now, we have different examples of functionalized sorbent material, such as polyamide fiber, polystyrenic fiber, copolymeric particles that can be functionalized with different things. One example is polymyxin B, for example. What are the forces involved? Not the gradient anymore, not the transmembrane pressure for convection, but van der Waals, ionic bonds, and hydrophobic bonds. And here is how we apply sorbent in practice. Direct hemoadsorption, then we have hemoadsorption plus CRRT or dialysis, or we can operate plasma separation and circulate the sorbent through the plasma through a sorbent cartridge. Now, we have seen recently indication for hemoperfusion, hemoadsorption, plus hemodialysis for chronic dialysis patient in patients with specific symptomatology. And the easy application of a cartridge before or after a dialyzer led to make different studies that have been recently published in Blood Purification. One is almost 1,500 patients treated as a control therapy, standard hemo or hemodiafiltration, versus hemoadsorption once per week plus hemodialysis. And this is another study on almost 500 patients with the same type of design, but including possibility of high and low flux dialysis. And in all the studies, there was a significant improvement in middle molecule clearance and on symptomatology. So I wrote this paper about the fact that I think we are today with adsorption where we were with the CRRT 30 years ago. And we need more research, we need more information. Because the application is rather easy, as you can see here. The application was already known in the past for intoxication or drug overdose or industrial toxin. And the result was very interesting because, for example, for some of these toxicants, the rescue success is very high and very impressive. The other thing is the application of sorbents in critical illness, especially in sepsis, where the so-called cytokine release syndrome seems to be one of the most important aspects. But there are several indications, including burns, trauma, cardiac surgery, pancreatitis, etc. Now, I'd like to point out that we recently published in Critical Care the concept that there is a time window for treatments, and we have, according to the cascade of sepsis, for example, the presence of pathogen, the presence of endotoxin, cytokines, and then finally organ failure. So at the beginning, for example, adsorption of viral particles or bacteria can be possible with a specific device that has been recently presented. Adsorption of endotoxin in the subsequent phase is possible through this type of sorbent that has been designed for adsorption of endotoxin, and in vitro and in vivo results confirm this, as we confirmed also in a specific prospective randomized trial in the past. While the most recent Euphrates studies failed to meet the primary endpoint, there was a signal in any case for patients with endotoxin between 0.6 and 0.9 with improved mean arterial pressure and hemodynamics and decreased mechanical ventilation time. Now, all this cytokine release syndrome can affect distant organ, and we have now devices that are able to be applied in conditions where cytokine elevation is present, and these characteristical sorbent particles have a range of adsorption that overcomes by far the capacity of typical membranes. So they end up to 60 kilodalton or 50 kilodaltons. Now, in the cytokine release syndrome, you know that there is a disruption of the immune response with high and low hyperinflammation and immunoparalysis, and what we need is a kind of immunological support. Now, years ago, we published this concept of the peak concentration hypothesis that having a specific removal of these substances may actually lead to lower the peak of the highest concentration of the mediator of the moment. So we don't need really to know what it is, but we will lower, having a kind of effect on the immunohomeostasis. And this has been demonstrated in several different studies showing significant reduction of concentration of cytokines and significant reduction of mediators independently on the pro and anti-inflammatory option. You see here, again, other patients with severe sepsis in which there was a significant change in interleukin-6, interleukin-8, and most of them SOFA score, which is the clinical effect that we are interested on. Again, another study with really difference in concentration of cytokines, although we know that these cytokines have a very short half-life, and sometimes it's difficult to biomonitor these cytokines. We also know that these cartridges tend to saturate after 6 to 12 hours, so we need to have more frequent sessions rather than a prolonged session. In the past, we also suggested the use of different extracorporeal therapies for cytokine removal in COVID patients where the immunological disruption was evident, especially in the first phase with the very high cytokine release syndrome. And in some patients, there was a death due to intractable inflammation. In some patients, there was a death due to immunosuppression. In both cases, the immunoadsorption and CRRT may have an impact on blocking the peaks of these substances, making a protection for the endothelial structure. Now, this is a case, for example, of a patient admitted with COVID on fever, mechanical ventilation, highly inflamed, treated for 3 days with immunoadsorption until normalization of the status and extubation after day 12. But the most important aspect is that not only we saw changes in cytokine concentration, noradrenaline requirement, and hemodynamics, but we saw an effect on the monocyte. The monocyte, which was paralyzed, started to respond again when incubated, for example, with the LPS, and showed again the capacity of phagocytosis. And this is a typical response in terms of reduction of the pro-apoptogenic potential of plasma in this patient and higher capacity of phagocytosis by the cells. But also, these cells start again to present the antigen. They increase the expression of HLA-DR on the surface, and there is an increase in the number of cells that actually present the antigen. So we have to be aware, however, that as in CRRT, with adsorption, we may absorb drugs that we have administered to our patient, and we have to be aware about the kinetics, especially the kinetics of antibiotics, because we want to deliver antibiotic after the session of immunoadsorption or adsorption in general. One last thing is that also acute liver failure can be treated with a combination of adsorption system on the plasma, modifying not only the concentration of bilirubin and bile acids, but also of the possible circulating mediators. And the application is possible with the current different machines. And there is a kind of meta-analysis that has demonstrated a similar capacity or even a better capacity compared to plasma exchange to induce improvement. We have recently published, both in critical care and intensive care medicine, a kind of review of this concept of the use of adsorption in critically ill patients. But we need definitely to consider that different molecules are present in different pathological conditions, and we can use diffusion, convection, and adsorption in combination. We are today with immunoadsorption where we were 30 years ago with CRRT. We need research. We need to define indication for each blood purification therapy. We need to establish the dose, frequency, and criteria for each application and each technique. We need to identify target molecules and biomarkers to do biomonitoring that often cannot be done. Like we do the ureakinetics in dialysis, we need to do biological kinetics of this molecule. We need to identify adequate endpoints for clinical trial, and we will do in June this year an ADCI meeting, a consensus conference on adsorption, but also one on endpoints for clinical trials in autumn. And we need to consider potential side effects and contraindication for each technique. I think that diffusion is an excellent mechanism to remove small molecules. Convection is indicated to remove small molecules and middle molecules having different membranes with different characteristics. Adsorption is an interesting option for blood purification, indicated to remove larger molecules. And different options are available for utilization of sorbent in practice. Sorbents may also be the doorway to wearable and waterless dialysis for the future. The question is, which one of these mechanisms is the best? Well, let me ask you, which is the best wine? Is it a Romanée Conti? Is it a Dom Pérignon? Or is it a Amarone? It depends, right? For example, what about if you have an Homard? You may want to have a Romanée Conti. If you have oysters, you may want to have a Dom Pérignon. And if you have a big steak, you may want to have Amarone. So it depends is the right answer on what is the target of your blood purification therapy. With this, you're all invited to join us in Vicenza in June for the CRRT and AKI meeting. As usual, it will be a great course. Thank you very much.
Claudio, thank you so much for that great overview. I think we have time for 1-2 questions. If you have them, raise your hand, and I may start. Would you foresee a constant role for adsorption in intensive care? Obviously, the answer would be yes. If yes, you see more specific, like anti-factor immobilized binding mechanisms, or more unspecific, you know? Is there a trend that you see coming?
When we started doing CRRT, our concern was just to treat uremia and AKI. And as we moved forward, we were more interested in re-equilibration, in immunological support, in different organ support, and also in prevention of further damage. So I think that for adsorption will be the same. We will just have one more option in our system. The important thing is that there are different indications. In the chronic dialysis patient, for example, maybe one session every week will be enough, or even 2 sessions. But in the ICU patient, you are playing your game in 6 to 24 hours. This is the time where you want to maximize your effort. And if blood purification is the answer, and we need to study this, I think that adsorption as an option. But we have to be aware that we have to select the right patients. Otherwise, we have the risk to have a positive, negative, neutral response, and then we say the system doesn't work.
So in other words, we need first randomized controlled trial demonstrating an impact on survival of this technique? No?
We will never be able to do the randomized trial that you want. 1,000 patients in this side, 1,000 patients that side. We will never be able probably to demonstrate an impact on survival because, as this morning has been discussed with Rinaldo Bellomo and Jean-Louis Vincent, all the perfectly designed trials are negative because of the heterogeneity of the population treated. We will probably end up with the possibility of a small group of patients or cluster randomization or whatever, but certainly not a large randomized trial. It has never been done for high flux membranes versus low flux membrane, but everybody now uses high flux membrane. So this is self-evidence, right?
Yeah. Okay, thank you.
Thank you.
Let's move to the next speaker. Is Lui Forni, that is going to talk us about can we predict who will need renal replacement therapy?
Well, Claudio told you the answer. I've spent 15 minutes sitting at the feet of the master, and he's just said no. So we can all go home. And the answer is Amarone all the time. So thank you all for coming. I know you didn't come to see me, but thank you all for coming. It's nice to see a full room. And I'm going to talk about this, who can predict renal replacement therapy. My conflicts of interest, apart from prescribing renal replacement therapy, aren't really a problem. So, can we predict, can we see the future, CRRT? Or if you prefer, CKRT, if you happen to read one of those terrible nephrology journals. Don't get me started on that. The problem with predicting the future, right, is it's particularly difficult, right? So as Mark Twain said, prediction is difficult, particularly when it's about the future. And that's what we're doing. So, right, there's a lot of youngsters in the audience, so I'll cut to the chase, right? We live in a modern world, so we don't need to think for ourselves anymore. We can ask the robot, can't we? Right? So, hey, robot, will bed 9 need CRRT at some stage? So are you thinking, has he gone mad? Well, maybe. So I did ask a robot, right? I asked ChatGPT. You all know what ChatGPT is, I hope. It's the online open AI engine. Had a lot of traction the last few weeks. It wrote me a love song for my wife, which I then played badly on the guitar. There's a new one from Google today, I think. So we asked ChatGPT what he thought. So I said, ChatGPT, can we predict who will need CRRT? You see, rather familiarly, ChatGPT referred to me as Lou, but anyway, that's nothing. So ChatGPT said, continuous CRRT is a form of dialysis used to treat critically ill patients, blah, 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 blah. There are some factors that have been identified as potential predictors of the need for CRRT. These include severity of illness, so patients with more severe illness as measured by scores like Apache or SOFA. Pre-existing renal function, so patients with pre-existing CKD or reduced renal function more likely to develop AKI. So far, ChatGPT was doing pretty good, I think. The presence of sepsis or septic shock. Fluid balance, patients with significant fluid overload may be more likely to require CRRT. And finally, I'm not altogether sure about this, but serum creatinine levels, elevated are often used as an indicator of kidney function, and those with higher levels might be more likely to receive CRRT. I was always taught as a boy, never start it on the basis of creatinine, and I still believe that, even though some in the audience here have done fantastic trials on timing where they have to use some form of cutoff, so I can understand why that's. So this is what the AI engine told us. Right? Didn't give me a predictive model. It just said, if you're sicker, if you're septic, if you've got CKD, fluid overload, and a high creatinine, you might need renal replacement therapy. Well, we have an expression in English, which is no shit Sherlock, right? So what that effectively means is, well, we all knew that. So if we look at AI in more detail, this is a predictive model of renal replacement therapy outside the ITU, right? So intermittent hemodialysis in the general population. In Taiwan, that has the world's greatest prevalence of renal replacement therapy, and they've got fantastic modelling with a C statistic of 0.95. In a stable outpatient population predicting intermittent hemodialysis, right? Our lot is completely different. This is a model we used a few years ago trying to predict acute kidney injury in emergency admissions, and we did okay, ROCs of around 0.7. Part of the problem is the indications for CRRT. And they might differ between institutions, they might differ between doctors, and certainly they might differ between experts. So Stéphane there, I think we can call as an expert, he may start CRRT at a different time or indication to me. And Claudio will almost certainly start it earlier than me. So there are no hard indications. So these are the ones we read, right? And I think most of us agree with that. These are the kind of slightly lighter ones, diuretic resistant fluid overload, limited tolerance to fluid overload. And they're softer, but these absolute indications are not that common. So we're asking predictive modelling to predict something that we can't really tell it what to predict, right? In terms of absolute numbers. Now, if you want to predict death, that's relatively easy when we're doing predictive modelling for that, because being dead is a bit like being stupid. Do you know that expression? So being dead, you don't know you're dead, but you are dead. If you're stupid, you don't know you're stupid, but everybody else does. So it's easy to predict death. But when we start AKI, there's a great deal of variation. Now, one thing that has achieved quite a lot of interest in terms of AI modelling is predicting discontinuation of CRRT. So we're on it, so let's see if we can predict if we can stop it. And there have been a few studies like this that have come out trying to predict liberation, none of which have been particularly useful. So are there other methods than modelling, right? And I mean, I do think that in the future modelling will help us, almost certainly. But are there any tests we can do to predict the severity of acute kidney injury and perhaps patients needing renal replacement therapy? Well, this is one you may or may not know, the frusemide stress test. I mean, most of my anaesthetic colleagues have been doing it for the years, but call it a diuretic challenge. But this is done under slightly more controlled fashion. Mink Chowler was the advocate of this years ago now, looking predominantly in cardiac surgery patients in the first instance. And they gave a fluid bolus, a diuretic bolus of either 1 milligram per kilo or 1.5 milligrams per kilo in patients who were not diuretic naive, and then controlled their volume balance, but looked at their urine output over the subsequent 24 hours. And they came with a cutoff of around less than 200 mils over 2 hours, put you at far higher risk of developing severe acute kidney injury. So we had a test which may predict acute kidney injury in patients at risk. So the next step is, can you do that to see who will require acute kidney injury? And there have been a few studies that have looked at that. And of course, because there's been a few studies, there's also been a systematic review and a meta-analysis. And if you like looking at these, which I don't have a great fondness for, but if you like looking at these, there's plenty of these for you to look at in this systematic review. And these are the FST predictions for renal replacement therapy. What the basic take-home message was the OROC, if you like that, was reasonable, but there was a very high heterogeneity between the studies. Diagnostic performance was certainly better in early acute kidney injury. But the main problem is that 25% of the non-responders that didn't respond to frusemide, so at a higher risk, may not need renal replacement therapy at all. And we know that from some of the studies such as Akiki. But 5% of the responders did need it. It's okay, that's all right unless you're one of the 20, right? So it's good, but it's not that good. And the main problem, as well as the criteria, is the optimal timing of initiation in the various studies. So what about biomarkers? Well, these haven't been particularly good either to date, right? And this was the last reasonable review by Sebastian Klein, who was a fellow of Michael Ioannidis, who looked at this, and their conclusion was that several biomarkers show promise about the prediction of renal replacement therapy, but certainly there is no evidence to support their routine use to guide decision-making. There are a few areas where there are quite good predictive modelling. Continuous RRT in liver transplant patients, this is particularly good. And again, you can see that the factors involved, hepatic encephalopathy, whether a deceased donor, are all markers of severity of illness. So can you combine functional markers, like a frusemide stress test, with a marker of damage? That might be the way to go. So we can have a two-pronged approach and see if we can predict who needs RRT. So this paper is currently in press. Here we combined frusemide stress test, predominantly driven by Alex Zawok's group, and used the biomarker CCL14, which is a marker associated with Th1 to Th2 transformation, so it can be a marker of fibrosis in the kidney. So you missed the beginning, guys, but you'll still get the punchline. So this is a combination of FST with a persistent marker of AKI. So the CCL14, as I said, is a marker of Th1 to Th2 transformation of fibrosis, so persistent acute kidney injury. So marker of persistent injury plus frusemide stress test. 434 patients down to 208 after it was sieved. And this is the take-home message, really. So if you had a negative fruitamide stress test, which meant less than 200 mils of urine, I always find the terminology with the FST slightly confusing. But yeah, with the presence of CCL14 above a cutoff of 13, we had a fairly good predictor in this single-centre study of patients that would need renal replacement therapy, and a good, relatively good, negative predictor, where you can see the other markers, NGAL and DPP3, were certainly less good. So this is the first study that we're aware of that's used a renal stress test or a renal biomarker test with a renal biomarker with a stress test in terms of function. And so that application of such a combination may reduce variability. So it might be something to help guide us in the future. So to conclude then, remember this at the beginning, the robot? So I asked him, her, she, whatever you want to call the robot, any update on bed 9 and need for the CRRT. So this was the last message that ChatGPT gave me. Right? It's important to note that these factors, so the ones we talked about, being sick and having CKD, etc., are not definitive predictors for the need for CRRT, and each patient's individual circumstances will need to be considered when making treatment decisions. Ultimately, the decision to initiate CRRT will depend on a range of clinical factors, including the patient's overall clinical status, fluid balance, and response to other treatments. So what does that sound like? Yeah. Who would have thought it? Right? AI technology and ChatGPT seem to be advocates of personalised medicine. And with that, I thank you in this very hot room for your attention.
Thank you very much for this nice presentation. It's open for discussion, this session, for the floor. Any question? Here. A microphone here, please.
Thank you very much for this very nice talk. I have a question. The question of the talk was, can we predict who will need renal replacement therapy? But my question is there any benefit to predict renal replacement therapy? Because if I have something to predict, for example, need for invasive mechanical ventilation, do I should start mechanical ventilation now? I don't think so. So my problem is, for which benefit?
Okay. Well, that's a very nice question, Stéphane. Of course, as you know, John Louis gives us the title of our talk. So that was the title I was given. Now, I'll give you an example where it might be useful, okay? So you're asked, Professor Gaudry, there's a patient on ward 7, that, I don't know what your wards are called in Boulogne, but you go up and see them, and you think, well, the creatinine's been deteriorating a bit, the potassium's kind of creeping up a bit, the fluid balance I haven't got quite right, and we can sort these things out. But do you think we'll be able to get away with it on the ward, or do you think we'll be able to bring them down because they're going to progress and perhaps need renal replacement therapy? So there, you might need an option. Now, if you're in parts of Germany or the US and you've got thousands of ITU beds, it's probably not an issue. But where, if you work in the cash-strapped NHS, and be able to predict, is probably useful. But you're right, I get exactly what you're saying, but in some ways predicting who doesn't need it is probably more useful than who does. So good question, Stephen, but I can't really answer that now.
These 20 or 25% of negative prediction with the furosemide stress test, what do you think, how much do we get away from that in combination with the markers you measured?
Or the colleagues it drops significantly.
It will drop.
It drops down to about 5%.
Okay.
So it certainly does help from that point of view, having the combination of the two.
The real question is, do you see urinary biomarkers having a standard role in the future in intensive care?
Oh, boy. I mean...
We just have the time for this question. So.
Yeah, I think if I'm hand on heart, honest, right, as we stand at the moment, there's been a lack of supportive data in some areas, right, in some areas. If we look at some of the intervention trials, I mean, there are, the Prevaki 2 that we're doing there, using biomarker initiated treatment strategies, then there is a glimmer of hope there in identifying patients that might benefit early from the treatment. Because you've got to remember that at the moment, our treatments are all preventive, really. And so if we can highlight early, then perhaps preventive treatments are better. Now, I can't tell you, much like Mark Twain, what's going to happen in the future. Right? But if we develop pharmaceuticals that can directly affect the course of the disease, then we may find that specific biomarkers have a place. So, if we look at staining, animal studies, where you look at staining with KIM1 or NGAL or whatever, you can see a difference in staining depending on the insult. So you can imagine a situation where you may use a combination of biomarkers or a particular biomarker that might say this is X, and if you treat with Y, you're going to have a better chance of success. At the moment, it's difficult. But, right, as a speciality, we cannot, please, right, just try to lose some of the negativity. Whenever someone comes up with a new idea, the response in intensive care is, no, don't like that. That doesn't work. I didn't think of it, so it's not my idea. So what we need to do is try and embrace some of this and think of how we can apply it and what it might be useful. And if we do that, and they've shown to be rubbish, then I'll be the first to stand up and say it.
Thank you so much, and we move on to the next speaker. It's Rinaldo Bellomo, and he'll talk about how the choice influences recovery.
Thank you very much. It's always a lot of fun after Louis. It's great. Conflict of interest statement. And, this statement from Erasmus of Rotterdam is about investigating and trying to understand what goes on. One of the interesting things about intensive care, from my point of view, is that there's a lot of interest in ventilator-associated lung injury, and the amount of literature and studies around it is massive. But there is a lot less investigation about acute dialysis-associated renal injury. And it's a paradoxical situation because both of them represent artificial interventions, both of them have got analogy in terms of the potential for harm, but the investigation is much less. So whilst there is ventilator-associated trauma, there is very little about nephron-associated dialysis trauma. And yet we've got reason to believe that this happens. We've got reason to believe there is barotrauma during dialysis. It's not the barotrauma of ventilation, it's about the low blood pressure causing injury to the recovering or to the injured kidney. There is reason to believe there is volume trauma, just like ventilator, but the volume trauma is due to intravascular volume depletion during dialysis. So these factors are likely to be important in dialysis as they are in ventilator-associated injury. Let's have a look at why I'm saying that. Now, the story of this begins a long time ago during the Vietnam War, where young soldiers were injured, a hemorrhagic shock, they developed acute renal failure, they were admitted to MASH units, and they were started with hemodialysis. And one of the things that doctors observed, and this is very nice work from the 70s, was that these patients would get better, they would be sitting there and it would be just fine, and everything was okay. The hemorrhagic shock was treated, the wound was treated, they weren't septic, they were okay, but they just wouldn't recover from renal dysfunction. And that was something that puzzled people because these patients should have recovered. And what they noted was that the consistent fact that this lasted a long time, for 3 or 4 weeks after the injury, and they try to understand why that would happen. And they looked at the hemodynamics of these patients. They say, there really is not much happening, and they have a little bit of systolic blood pressure or hypotension, but for a young man, that shouldn't really matter. And then they went to do biopsies, and what they found was there were fresh injuries and areas of hemorrhagic injurious nephron damage in these people that should have been okay. And they couldn't really understand why that would happen. So they went on to do animal work, and they had animal models, so where you had acute kidney injury due to hypotension in rats that had developed acute renal failure versus controlled animals. And you could see that if you had a control animal, there was nothing happening. But if you had a previous episode of ischemic acute kidney injury, every time you gave the animal a degree of controlled hypotension, there was a surge in creatinine and there was loss of GFR as represented by creatinine clearance. So In a normal animal that's got the ability to achieve a degree of autoregulation of renal blood flow, things are not that bad if you have a degree of hypotension, but in an animal that's got acute kidney injury, hypertension is particularly problematic. Does this kind of hypotensive or a dialysis-associated injury happen in human beings? This is work done in patients receiving chronic dialysis. This is a positron emission tomography image, and you can see the perfusion in green, and then you can see under peak dialysis stress, it's completely disappeared. You can see that another patient in green, some degree of perfusion. These are kidneys with chronic kidney disease, and again, there is loss of perfusion. So in the setting of dialysis in chronic patients that are not critically ill, they're not septic, they're not unwell, they're just coming in as an outpatient situation, you have significant loss of renal perfusion. Now, when you do dialysis, you also affect the heart, and Louis has shown this before. You have significant myocardial stunning during intermittent hemodialysis in the ICU patients. And this is likely to change the cardiac output, this is likely to decrease flow to the kidneys, and it's likely to contribute to further injury in these patients. And so we've taken the liberty to kind of do some really interesting investigations. And so there is technology, that's a ClearSight technology by Edwards. You can put it on the finger of the patient, it does pulse contour analysis and delivers a cardiac output assessment. And then we looked at what was happening to patients receiving intermittent hemodialysis in the ward after recovering from acute kidney injury in the ICU. And you can monitor intravascular volume with dialysis machines or with a Fresenius device that can attach to the circuitry, and you can monitor cardiac output in these patients. And what you can see is a patient like this one where the blood pressure doesn't change at all, and you just don't have anything happening, except that you've got 8% intravascular volume depletion, and except for the fact that the cardiac index has gone 3 liters from meter square per minute to 1.8 liters per meter square per minute. So you've got a very dramatic, almost 35–40% decrease in cardiac output, in flow. You've got a significant degree of intravascular volume that you wouldn't know it was happening unless you were measuring it. And the blood pressure is okay, which means that there is a significant surge in vascular resistance. And that can only be related to catecholamine release, and all of that is unlikely to be good for the kidney at all. What do we know about data in the literature? So we know from the trial that Ravi Mehta conducted about 20 years ago now. These are patients randomized to continuous renal replacement therapy or to intermittent hemodialysis. A small study for the things that we do now, but it's still reasonable, 160 patients. And this is the degree of chronic renal insufficiency and the complete renal recovery according to whether you use continuous renal replacement therapy or intermittent renal replacement therapy. This is observational data by the Best Kidney Group looking at the referential degree of recovery to dialysis independence in people treated across the world with intermittent hemodialysis or continuous renal replacement therapy, again showing that the intermittent therapy is associated with a prolonged duration of continued dialysis requirements. In a way, dialysis begets more dialysis, and this is clearly different when you do a multivariable model. We've also looked at the literature. Antoine Schneider was my fellow doing his PhD with me now about 10 years ago, and Antoine looked at the literature. This is a review of all the studies that reported on modality and outcome of patients with acute kidney injury and the degree of renal replacement therapy dependence in survivors according to the initial modality of renal replacement, whether you were looking at hospital discharge, 28-day outcome, 90-day outcome, or the longest outcome in a given trial, is always in favor of continuous renal replacement therapy. And if you try to understand the degree of exposure by looking at how often or how long the treatment was sort of delivered to the patients, you have the same signal that intermittent therapy is associated with a decreased chance of recovery of renal function. These are the data presented in a forest plot, and you can see that the observational studies are showing a benefit for continuous renal replacement therapy. But the randomized controlled trials do not. And it's very important that you accept that. We don't have enough evidence, we don't have enough numbers. You see the numbers are very small of patients randomized to CRRT or IHD to be sure that what we're seeing is not selection bias and it is a true signal of benefit. In order to try and understand this a little bit more, we looked at people according to duration of follow-up, and there is again a signal in favor of continuous renal replacement therapy. We looked at those that had chronic kidney disease that receive CRRT or IHD, and the signal again is in the same direction. But again, this is observational data, this is not randomized data. Then we looked at whether this is something that can be reproduced in other centers, in other settings. This is work by Ron Wald in Canada, and he looked at their Toronto database of patients that had been receiving acute renal replacement therapy according to whether they used continuous renal replacement or they used intermittent renal replacement therapy. And you can see that they were able to follow them up because of the connection with registries in this population, and you can see that there is a difference all the way up to a follow-up of more than 10 years in the percentage of patients that go on to be on chronic dialysis. And you can see that the signal is very strong in favor of continuous renal replacement therapy. Do we have any trials that can give us some more information about this? The two big trials before START-AKI were the renal trial and the ATN trial, the ATN in the United States and the renal trial in Australia and New Zealand. One of the features of these two trials, which was quite striking when they were published, was the difference in renal replacement therapy dependence at 28 days and 60 days. It was really striking. In Australia, it was at 20 days, only 13% of patients were still receiving a renal replacement. In the ATN trial in the United States was 45%. This is a really big difference. You try to understand where it might be coming from. And one of the characteristics that distinguished the ATN trial from the renal trial was in the renal trial, all the patients were treated with renal replacement therapy, which was continuous, whereas in the ATN trial, a significant proportion of patients were treated with intermittent hemodialysis. You can see that the number of dialysis sessions was significantly different between the two groups. We were then able to obtain the data from the NIH, which has a repository of the ATN trial in it, so that we could actually get the baseline characteristics of the patients. We already had the baseline characteristics of the renal patients, then we could create a joint database. We were able to then do individual patient baseline characteristic adjusted of the models to associate a particular intervention with a particular outcome after adjusting for baseline illness severity. And when we did that, we were able to then look at patients that were very moderately ill, and this is a SOFA score less than 2, and those that were more critically ill with a SOFA score above that. And when you look at the relationship, adjusted for a lot of baseline characteristics that were available to us now that we had created a joint database, that there is a signal in favor of decreasing renal replacement therapy dependence if you use continuous renal replacement therapy as the initial form of treatment. And the risk is about a 50% decrease in risk. And if you look at renal replacement therapy free days, mortality, as well as renal replacement therapy dependence at 28 days in patients that have got a SOFA score of 3 or above, cardiovascular, so these are people that are hemodynamically unstable, then the signal is even stronger in favor of using continuous renal replacement therapy rather than intermittent renal replacement therapy. So all of this information to me means that there is a signal that the choice of modality in patients with AKI actually does matter. I think there is a signal that some of it may be volume trauma by intravascular volume depletion. I think there is a signal that some of that may be barotrauma because there is low blood pressure. There may also be other aspects that we haven't been able to look at. They may be related to metabolic trauma with patients having a different metabolic state and a different acid-base physiology. We don't know yet, and we haven't really looked at that. But it consistently looks like on every way that we look at this, every time we analyze it, there is a signal in favor of avoiding intermittent hemodialysis. Irrespective of that signal, the entire area of kidney injury from renal replacement therapy, whether it is intermittent or continuous has really not been adequately analyzed, not at all in the way the ventilator-induced lung injury has. And I think, in my mind, there is a huge program of focusing on that and improving both the quality of intermittent therapy and the quality of continuous renal replacement therapy. Thank you very much.
Thank you so much, Rinaldo. It's open for discussion. You have questions, raise your hand. Get a microphone. I start seeing chronic dialysis patients entering the program and having residual function. You know, that's a very similar observation, you know, that they in a short time often lose it. You think it's a similar mechanism probably?
I'm sure you're aware of the data comparing peritoneal dialysis to intermittent hemodialysis in people that enter the program because some residual function. If you have peritoneal dialysis, the loss of residual function is significantly less and significantly slower than if you have intermittent hemodialysis. So even in the chronic setting, having a gentler, hemodynamically sort of softer intervention as 12 hours or 8 hours of nocturnal peritoneal dialysis as opposed to 4 hours of intermittent hemodialysis is associated with differential changes in residual function. Absolutely.
So we could learn from each other. Would you think it's for intensive care, it's always continuous, or should we do intermittent just differently?
So I think both of them are options, I think that there is an option for doing intermittent better. I think, the patient is in the ICU, they don't want to go home, right? One of the advantages of intermittent therapy, of course, is people go home. But they're in ICU, they're not going anywhere, so you can make a very reasonable argument that doing 10 hours or 8 or 9 hours of gentle dialysis, removing the fluid you want to do, achieving what you want to do, maybe at nighttime while the patient is not really being mobilized, and then mobilizing the patient in the morning and be able to do that is a very reasonable strategy. However, we don't really have very good control data on SLED or slow, low-efficiency dialysis, but I think it's a logical and very reasonable thing. On the continuous side, I think there are problems as well, and a continuous renal replacement therapy is not free. We are removing stuff that might be good, we are removing amino acids that might be good, we're removing vitamins that might be good by doing continuous therapy. So there's somewhere in between, I don't know where that is. So all of these things require a lot more attention. And so, and I also know, because we've just recently done some work, that during continuous renal replacement therapy, there is also intravascular volume depletion. And it happens in people that are treated acutely and early who have vascular permeability issues. And so these people are spreading their fluid outside of the intravascular compartment. You start dialysis early, you want to take fluid off, they cannot have capillary refill. They're actually having exudation of fluid. And what happens, even if you're thinking you're doing moderate fluid removal, 150, 200 mils an hour, you actually induce intravascular volume depletion, even with CRRT. So there is trouble at every level, and I think we need to pay more attention.
Okay, thank you. We move. Thank you. We move now to the next presentation. Is CVVHD is so much better than CVVH. The talk will be done by Xose, Pérez, Fernández. Thank you for coming.
Thank you. Good afternoon. I'm a little bit embarrassed to talk after the three guys I have talked, but I try to do my best. My name is Xose Pérez. I come from Barcelona, Hospital de Bellvitge. I'm part of a research group that involves 3 big hospitals in the metropolitan area, which is Can Ruti, Sant Pau, and Bellvitge. And we try to do some research in the context of public hospital, which is not always easy. And this is my hospital, which has a nice Gaudí architecture, as you can see. But when you get to Barcelona by plane, you will see when you enter Barcelona at left hand, that's my hospital. This is Joan Sabater with me, and I wanted to put this slide because this talk is like a kind of catharsis. No? We tried all drugs, all machines, all devices in the last 15, 20 years. till we get to some small conclusions that probably less is more and don't harm the patient, etc., etc. But so that's the reason basically why I'm here. I don't know why you're here, but probably to listen to the three guys before me. But I'm sure you have also some experience with this kind of machines. This is a CPFA. I don't know if we call it Linda. We use it in some patients, fortunately in the last stage of the disease, but we try to do some resuscitation therapies, which were obviously failed in most of the cases. I have conflict of interest, not related to this talk, but to the talk we will have tomorrow. I invite you at 10:15 to listen to the preliminary results of the CRRT2 trial, but it's not the subject of the talk today. This is my supper yesterday, kidneys, of course. So I'm full of kidney energy, and I hope not to bore you too much. Basically, we'll run through the sepsis-associated AKI, which is the subject of the study we performed, and I'll tell you about the trial we performed 10 years ago. So in 2012, we had this kind of evidence about dose. We came from the big trials. Rinaldo has referred, Renal study and ATN study, of course, and we were moving still in a high dose because 25-30, just in case we have to remove some inflammatory mediators. We used the conventional cutoff membranes, less than 40 kilodaltons, not important not to lose things, but we were not sure if we were doing convection diffusion or we had to do intermittent. I must admit, Stéphane, sorry, we are continuous for the moment still, but that's the way we learned, that's the way our nurses are trained, but obviously intermittent can be a good alternative. And at that time, in 2012, we still didn't know if early or late. There was a trend to be early in the septic patient, but obviously that was published later. And of course, you all know that we can be a little bit delayed in the initiation of therapies. Dose, as I told you, was decreasing at that time. Membranes, we had a bunch of membranes. We were in the septic era with a high cutoff, absorption devices. Don Claudio has told us about the advantages of removing all kinds of molecules with absorption cartridges and devices. But we were not very sure if we're doing right or not. Which modality should we use in this patient? Should we be diffusive or convective? And my friend Jeffrey Fleming from Vanderbilt told me once that a guy called Golper, who was one of the fathers of the SLED, used to say that intensivists were always confused because we never knew if we have to be convective or diffusive. So for him, we were always confused. And that was true at that time because we were not sure if we had to be still a little bit convective because those inflammatory mediators, middle molecules had to be removed out from the circulation. Claudio was strong in his postulations, trying to remove or minimize these inflammatory peaks or anti-inflammatory peaks, which has some possible benefit, which was not demonstrated with the big dose trials, but we still thought that maybe convection was at some point good to remove these middle molecules. We had the CVVH with the option of doing convection and the advantages of removing these inflammatory mediators, and we have CVVHD with diffusive properties with small molecules, as has been nicely shown, that is nice and easy to dialysate our patients, even in continuous modality. So, besides that, we had the absorption properties intrinsic to the membranes that were being developed, and at that time, we settled a hypothesis. Can septic acute kidney injury, which is the standard of inflammatory AKI, can be supported with continuous veno-venous hemodialysis using a normal filter with some absorption capacity like ST150, AN69, with absorption with cytokines and a little bit of recovery with polytinamine to reduce its reactivity? well, we were fortunate. It was the same day that the Costa Concordia was sinking. We were fortunate lucky to obtain a grant from the government of 27,000 euros, which is a big amount of money. And with that, it was our first grant from the government, we were very happy at that time, of course. We designed the trial trying to demonstrate if really in this critically ill population of septic patients, really inflamed, really with hemodynamic instability, if continuous veno-venous hemodialysis could be as good or could be as bad as CVVH in terms of survival outcome. This was a pilot randomized control trial, probably absolutely underpowered, but our idea was to demonstrate a non-inferiority in terms of survival with probably a benefit in terms of filter patency, a longer life of the membrane with less dilate trauma, and the same immunomodulation capacity. For this trial, we basically designed an exchange of the filter every 24 hours. We still believed at that time that it was important to remove those inflammatory mediators, and due to the possible saturation of the membrane, we decided to change the membrane every 24 hours, which you will see was probably a mistake. So every 24 hours during the first 72 hours, the filter was changed. We measured cytokines. We performed in one group CVVH and the other group CVVHD. Patients were included within the first 72 hours of ICU admission, which was quite early. And this is a little bit the randomization, how patients were eligible. Finally, we had like 54 patients in the CVVH group and 56 in the CVVHD. So results, basically what we tried to do in the CVVH group was to maintain our filtration fraction always under 20%. So that means that we did per filter substitution and post-filter substitution at the same time. 25% of the patients were on heparin at the initiation of the study. At day 4, nearly 50%. And as you can see, the dose was quite high, with nearly around 29, 32 ml kilo. The characteristics of patients were mostly pneumonia, intra-abdominal sepsis, and with a quite high percentage of bacteremia, around 41%. And as you can see, we had an initiation quite early from respect to the ICU admission time of nearly 17 hours. But most of the patients were in really advanced stage of AKI. Most of them were in stage 3. Most of them were on vasopressor support. They were really sick patients. As you can see, the mean time on CRT was around 5 days. We had more or less the same amount of dilate trauma, probably to the small sample. When I talk about dilate trauma, I mean transfusion and electrolytic disorders related to the modality. And in terms of results, we had no differences in terms of survival. A trend to have a higher or a longer filter patency with the use of CVVHD, but here's where we probably penalize because of the changes between every 24 hours during the first 72 hours, because probably we haven't changed the filter so many times during the first 3 days, we will have differences. We have observed differences. No differences in terms of cytokine clearance, which was very interesting because at that time convection was meant to be the modality when you wanted to remove cytokines out from the circulation, and measuring basically logarithmic change from baseline to after 72 hours, there was no differences in these 5 cytokines that were measured. Of course, no differences in terms of hemodynamic response, mean arterial pressure, norepinephrine requirements, SOFA score, or respiratory function. So our conclusions were basically that there were no differences. CVVHD did not present differences compared to CVVH in a septic AKI population in terms of survival. In filter patency, there was a trend, but it was not significant. Dilated trauma events, cytokine or solid concentrations, and hemodynamic and respiratory support. The study is not published for obvious reasons. Here we have all the synonyms, but probably Lucer is the most adequate. But what have we learned from that study? At least in my department, and probably in the other two centers which were part of the study, we learned, and this is real data, how a convective dose has decreased in the last years, and how diffusive dose has increased. We are less convective, we are more diffusive. I don't know if that's correct or not, but that's what we're doing. And we also learned some things from the COVID. Besides getting angry with some good friends or sharing good things with others, we also learned that filters, the longer, the minimal filtration fraction, I mean, the less convection you did, the better. The longer life you had in your filter. So this is a recommendation from ACTI, which says that they suggest the use of continuous venovenous hemodialysis or even CVVHDF to decrease filtration fraction and reduce the risk of circuit clotting, which is probably applies also for all septic patients and not for COVID patients, although we all know about the prothrombotic state. But I'm sure that we all have the idea that septic patients are all prothrombotic. And we keep learning because this was published very recently. This is a PLOS ONE journal, and the group from Iowa has published that CVVHD results in a longer filter life than per filter CVVH, and this is a nice randomized control trial they have performed, and where they clearly show how the life of the filter increases with CVVHD. We were not able to demonstrate because their sample, of course, is much bigger than ours. So my recommendations is that I think I'm not longer confused. CVVHD is much better than CVVH, unless maybe you want to remove myoglobin. I don't know if that's right or not, but it's an option, a big rhabdomyolysis, that you have a 17 kilodalton protein moving around that may harm your kidney. You maybe are allowed to use some convection. Or maybe your citrate needs convection, your system of citrate anticoagulation needs convection. That depends on the brand, of course. Or unless Stéphane finally demonstrates that intermittent hemodialysis is much better than CRRT, but we still don't know that. So what is clear is that pediatricians, and this is Jeffrey Fleming that left us in 2020, he was a very good friend of mine from Vanderbilt, showed me that we had to do some convection only in the post-filter earth camera of 200 ml. That was what they did in children to avoid coagulation. And that was the only convection they performed. The rest was diffusion. And with this, I invite you to participate in our symposium, which will be in October in Belvidere Hospital. You can visit the city afterwards, of course, which is much beautiful than the surroundings of my hospital. And thank you very much. This is my email. If you have any question, please write me, and I will be very pleased to share with you.
Thank you for this fantastic presentation that is open for discussion. Questions from the floor? Raise your hands, please. Any question? I have one for you. Well, since 2 decades, I have always performed convection and diffusion in my ICU. Maybe it's the election between one and the other is not real, and what we should do is to change the technique, considering where the patient is. At the beginning, when at admission with a patient with septic shock, maybe you will need more convection, and no? Or 50-50 convection diffusion, and later on you can decrease this convection. What's your opinion?
My opinion is that convection has demonstrated a benefit in chronic hemodialysis patients, as far as I know, convection, because you remove some proteins that are doing harm to those patients who are on chronic dialysis. But on acute patient, I don't find a reason to do convection. I think that nowadays, I'm not sure if removing inflammatory mediators is beneficial for our patients. It's clear that high concentration of inflammatory mediators is related with worse prognosis. That's clear and easy to understand, but there's no study that demonstrates that decreasing these inflammatory mediators is beneficial for our patient. For me, it's clear that with diffusion, you are much protective. You have probably less dilate trauma, less problems with antibiotics, which I haven't talked about. And I don't know if maybe some impact on renal recovery, which is not demonstrated yet, but I don't know if maybe there's some effect too, in the, which has not been, of course, demonstrated too. But I feel much safer doing diffusion, and in fact, the filter life is much longer. And of course, this study with the use of citrate has been a little bit relegated, but we observed with COVID that we were not able to use citrate because there were no nurses that knew how to use the machine on the protocol, so we were obliged to or compelled to use again the CVVHD and at that point it was clear that the diffusion was much safer and the filter life was much longer.
Okay.
I have one more. You mentioned you used AN69. I mentioned it's an adsorptive membrane. Was that important? What did you expect is adsorbed? And part two of the question is, there's other filters that have adsorption as an add-on function. You know, would you imagine that is more important in the future?
I think we don't know really how much absorption. I mean, AN69 is a clear membrane that absorbs cytokines because it has due to electrical properties. So you will bind cytokines. But we still don't know if that binding is much more effective with convection or with diffusion. Because it depends on the blood flow you're running the machine. It depends on the ultrafiltration rate you're using. So I don't think we have an answer to the absorption properties of the membrane in convection or diffusion, at least as far as I know. So I think that with the property of the membrane with diffusion, I think we demonstrated a small sample, of course, but there were no differences in cytokine profiles. Or clearance, basically, and we feel quite safe in that sense. About the new membranes coming, well, I invite you tomorrow to the talk because we will talk about in an absolutely different scenario. I mean, we will talk about cardiac surgery patient, not septic patient, a more controlled scenario. There may be a benefit.
Well, thank you very much. And we move on to the next presentation, and that's from Tomoko Fujii from Japan. And I just learned that Tomoko means intelligence, so that we're looking forward to your lecture, How to Effectively Prolong CRRT Filter Life. Welcome.
Thank you very much. I really appreciate this opportunity to speak about renal replacement therapy, which is my main interest of my research. And I would like to thank the moderators and the organizers of this fantastic symposium. Thank you. So let's get started. So disclosures, nothing relevant to this talk. So I'm quite convenient to talk about that. Continuous mode is more favorable than intermittent mode now. So according to a multinational international observational study, 75.2% of renal replacement therapy sessions were conducted with CRRT continuous mode in 33 countries. And continuous renal replacement therapy is typically provided through a double lumen venous catheter, and it is supposed to work continuously over 24 hours. However, it is quite under-recognized that CRRT operates less than 24 hours, particularly those patients who go out to operation theaters or other imaging tests. And some studies show that in some patients, CRRT operates 16 to 23 hours in a day in actual clinical settings. So, due to the characteristics of the extracorporeal circuit of the CRRT, we have to take some measures to prevent the clotting. And according to the single-center observational study conducted in Australia, I suppose, showed us that clotting of the circuit is the most major reason of the interruption of CRRT, and followed by clogging of the membrane, and yes, as I said, transports outside of the ICU, like operation theater or radiological imaging tests. And unfortunately, these interruption of continuous renal replacement therapy can cause decreased CRRT dose, which means insufficient solute or fluid control, and of course, increased medical costs and workloads of healthcare professionals. So the major strategy to prevent filter clotting should be anticoagulation, but critically ill patients are mostly at high risk of bleeding, and some clinical trials show that 25 to 50% of ICU patients on CRRT were treated without any anticoagulants. So it's important to think about how we can prevent the filter clotting by non-pharmacological strategies like access site, blood flow rate, or CRRT modalities, and hemodilution. So let's start from the mainstream of the pharmacological interventions. These are the major anticoagulants that are used for CRRT. The most major ones should be unfractionated heparin, low molecular weight heparin, and recently citrate is maybe the most or the second most popular one. And very less commonly, nafamostat mesylate, argatroban, or other anticoagulants like warfarin and antiplatelets are used. And of those, the most investigated anticoagulants are regional citrate and systemic heparin. And systemic heparin is sometimes compared with low molecular weight heparin, but very few evidence are available for other anticoagulants like nafamostat mesylate or other thrombin inhibitors. So there are very limited evidence for these minor anticoagulants. According to KDIGO guideline 2012, for anticoagulation in CRRT, they suggest using regional citrate anticoagulation rather than heparin in patients who do not have contraindications for citrate. The level of evidence or certainty of evidence was very low until the RICH trial reported the benefits over unfractionated heparin. And for anticoagulation during CRRT in patients who have contraindications for citrate, they suggest using either unfractionated or low molecular weight heparin rather than other anticoagulants. So they did not mention any other anticoagulants in this guideline because there is few evidence around other anticoagulants. So I think we can learn much more about RICH trial or regional citrate anticoagulation later on, but I would like to introduce very briefly. The RICH trial was conducted in 26 ICUs in Germany, and it recruited almost 600 patients, and the trial showed prolonged filter life with regional citrate anticoagulation when compared with systemic heparin anticoagulation. And also, it showed reduced bleeding complication, which was really fantastic. And I think this is the best and only evidence that showed one anticoagulation strategy is beneficial than other anticoagulation strategy. So there are some trials that compared unfractionated heparin and low molecular weight heparin, but as you can see here, all the trials were very small in size and they recruited very small number of patients. So the evidence came from this data cannot provide any convincing evidence to use unfractionated heparin over low molecular weight heparin. So nafamostat mesylate, I think almost none of you know about this anticoagulant. This is a synthetic serine proteinase inhibitor, which is mainly used in Japan and South Korea, and it has molecular weight of 500, and it blocks the anticoagulation cascade, inhibiting complement-mediated hemolysis, and then can use as an anticoagulation strategy for CRRT. And it has short half-life of approximately 8 minutes. So this is the reason that some East Asian people prefer to use this. This anticoagulant became a bit popular or attract some attention in COVID-19 pandemic because thromboembolic events were quite common in COVID-19, and also ECMO was required for many patients. And we need anticoagulants, even for patients who cannot use heparin. But there were almost no evidence around this anticoagulant, so we did an observational study, compared nafamostat mesylate and unfractionated heparin with almost 300 patients. Unfortunately, the study did not find any superiority of nafamostat mesylate over unfractionated heparin. In fact, unfractionated heparin was associated 1/3 to 1/2 a day longer filter life than nafamostat mesylate. So this may sound like the end of the day for the nafamostat mesylate, but I would like to note that the optimal dosage of this drug, nafamostat mesylate, has yet to be investigated, so there may be some place to further explore this drug. So let's move on to non-pharmacological interventions. The KDIGO guideline recommends using right jugular vein as a primary recommendation. I think probably those are based on observational studies. But when we think about the Poiseuille's law, excuse me for the pronunciation, Poiseuille's law, correct? A thick and short catheter may be theoretically preferable. And also to avoid kinking or curving of the catheter, right jugular venous route should be preferable one. But surprisingly, there are very few evidence that showed right jugular approach is superior to other sites. I think this is the only randomized clinical trial compared different access sites. So this trial recruited patients having continuous renal replacement therapy or intermittent hemodialysis and compared femoral access and jugular venous access. They recruited 750 patients, but they showed little difference between femoral or jugular catheter placement in catheter survival. So blood flow rate. So how about high blood flow rate? So some may recommend using greater than 200 mils per minute of high blood flow rate for continuous renal replacement therapy. But according to the recent Cochrane reviews, there are only 2 randomized control trials that compared different blood flow rates. And the available evidence from almost 500 patients showed no difference between the groups. But as you can see here, the confidence interval is quite large, wide, so the level of evidence should be low about these findings. So another thought would go to convection mode, avoiding convection mode. So randomized control trials, several randomized control trials have been done comparing using convection mode or not, but rarely they reported filter life. So in the view of filter life, limited data are available from randomized control trials. And the observational data showed no difference in filter life, which was published in 2021, and it showed median filter life of 16 hours in both groups. So in summary, benefits from any pharmacological intervention compared to no pharmacological intervention are uncertain, particularly in patients at high risk of bleeding. And if there is no contraindication, regional citrate anticoagulation is the first choice as a pharmacological strategy to maintain filter patency. And definitely clinical research is needed to investigate which or whether anticoagulants should be used for patients at high risk of bleeding or patients with contraindications to the regional citrate anticoagulation. And as for non-pharmacological interventions, jugular access does not have evident superiority over femoral access in terms of filter life. And keeping blood flow rates greater than 200 mils per min appears not to prolong filter life. And the evidence is uncertain whether convection-dominant modes may shorten the filter life. But in general and overall, up-to-date evidence on the non-pharmacological interventions or pharmacological interventions other than regional citrate anticoagulation is lacking. Thank you very much.
Thank you. And we have a question. Please get a microphone. Can we have a microphone?
Just a small comment on the convection and diffusion. According to a REACH trial from Professor Tabrock, there is a multivariate analysis. There's clear evidence that CVVHD is better in terms of the filter lifespan, and it's dominant over the CVVH or CVVHDF. So we have a clear randomized control trial evidence about this. Thank you very much.
Thank you very much for reminding of the data. Yes, so I would like to add a comment that the Cochrane review was conducted before the REACH trial was published. So yes, thank you very much for the comment.
It's quite impressive that it's okay?
Yeah.
Okay. About the blood flow, it's quite impressive that it doesn't make any change in the filter life, which I think we all have the idea that there's a big difference between high flows and low flows. Do you think that maybe the use or not of convection is related with this? Of course, if we go very diffusive, probably the effect of blood flow is less important, but if there's still an important convection, you need a blood flow, a high blood flow. What do you think?
So some studies investigate into the blood flow rate, mostly uses filtration modes simultaneously. So probably something is confounding the effects. So we cannot tell clearly if blood flow rate is not effective at all, because high quality research or randomized control trial is not enough. So I think there is still a room to investigate that.
One question. What about citrate in patients with liver failure? I work in a liver ICU, and we try to avoid citrate because of the metabolism in the liver. But you talk with a nephrologist and they say, okay, we can do, check the calcium or whatever. What do you think? We can use citrate in cirrhotic patients, for example?
Some research says high lactate levels or liver failure is not a definitive factor to avoid regional citrate anticoagulation. But when we use citrate, we very, very carefully monitor lactate and calcium levels to avoid any additional adverse effects. So if you can closely monitor those variables like calcium levels and lactate levels, you should not avoid, you do not need to avoid using citrate necessarily, but if you have another choice, that will be, you know,
maybe the choice is not to use anything.
Yes.
50% of the renal replacement therapy that we perform in my unit are performed without heparin, without citrate.
Yes, that's the available evidence showed us 25 or 50% of the patients do not receive any anticoagulants.
Until today, I thought it's a pity that we don't have access in Europe to nafamostate mesylate. But with your lecture, you know, I'd say that we don't need it. You know, is it? If you have a shorter half-life, did you stop using it, or?
Well, at this moment, you don't need that, but we're still working on investigating how we use the drug, the optimal dosage, or because the drug doesn't have any anti-drug to stop the effects like heparin, so we're still closely investigating it, how we can use, or if it is beneficial for us or not. And so you don't need to worry about at this moment.
Okay. Thank you very much. Let's move to the next presentation. It's regional citrate anticoagulation. The talk will be given by Joop Jonckheer. Thank you. Welcome.
Thank you. Okay. Hello, everybody. I'm Joop Jonckheer. I'm an intensive care physician. I work in a hospital a little bit further there. If you're on top of the panoramic room, you can see it with a little crane. I work in intensive care. I'm a pneumologist by formation, but my special interest is into nutrition. And so this is where my interest into citrate came. And so, doesn't work? The green one. Okay, yeah. So I'll be talking here about 10 things to consider when you're using citrate. So this is my conflict of interest that can be related to this talk. So I will take you on a voyage that citrate does from the moment that you start putting on your bags and the citrate goes into your patient until it is removed from the body or metabolized. It is quite an interesting voyage. For me, citrate is one of the most interesting molecules that we use in the ICU, but I might be a little bit biased, of course. So I'm unhappy. I'm suffering from encephalopathy, I'm having a terrible itch, and I have also, I'm anuric. And so I'm admitted in the intensive care unit, where the ICU physician asked ChatGPT if he should start CRT. Sadly, he has no answer, but he looks at my current state and says, well, yeah, we'll start some CRT to this patient. And so he starts CRT in the form of extracorporeal circuits using CVH or CVHD. I didn't have to talk from before until now when I made my presentation. He might add some post-dilution, but he will be adding also some pre-dilution. And hopefully he will be using citrate, for which I will be very happy too. And so we listened to it in the previous talk a little bit. I will be happy that you will be using citrate. Why? Because we know that it will diminish the major bleeding in the patients. So in me, when you're using CRT. Of course, there's no effect on mortality, but still, it is a major complication, so I would like to avoid that. And even more, you will have more filter lifetime, as we saw before. So the citrate would enter the extracorporeal circuit into the blood. And we use mostly, I think, in all ICUs, we use mostly trisodium citrate. And so the 3-sodium citrate will dissociate into 3 sodiums and citrate. In the blood, citrate will mostly exist for 91% of time, in 91% of time, yes, into citrate 3-, but in 9% of cases, this will exist as citrate 2- as a strong acid. It would chelate calcium, for which it will inhibit the coagulation cascade. And once you will reach ionized calcium below 0.4, that's the moment that your coagulation cascade will be blocked. And so you see here that in your extracorporeal circuit, before it enters the filter, you will have citrate calcium and sodium, which needs to be removed. And one of the issues that you could have in those patients is a lot of sodium that will accumulate in the patients, causing hypernatremia. Luckily, the sodium will be removed inside the effluent, whether you're using CVH or CVHD, along with calcium citrate and the calcium as an ionized molecule. And so you see here that indeed when you're using 3-sodium citrate as a pre-dilution, you won't have risk of hypernatremia. You see that in this study, when they started 3-sodium citrate 4%, at 24 hours afterwards, the baseline sodium didn't change at all. It did change a little bit when they were using dextrose citrates and heparin, as this probably will be removed more at the point. And then you see here also in this other meta-analysis that we saw before, where they only included one study, the CASH study, when compared citrate to a fractional heparin, and actually it did not change the amount of hypernatremia that would occur, which was very, very low. You see here 4 patients on 66 patients that were included, so you can ask yourself the question if it was due to the citrate, of course, as there was no difference with unfractionated heparin. The other problem, and we saw it before, is that calcium is removed. Calcium is removed as a free ionized calcium, but also bound to citrate. So we'll have two mechanisms through which calcium will be removed. And so that's why you will need to start calcium in those patients. Otherwise, you will have hypocalcemia, which can be deleterious in your patients. So we then go to the citrate removal, because we want to talk about citrate here. And citrate will be removed in your effluent with a sieving coefficient about 0.88 at 1. We use at our hospital 1 for the calculation that I will show you in the next talk. And that will be about 30 to 50% of the citrate that will be removed. So where does the other citrate go? Well, it will mostly go to the liver, but also to the kidneys and to the skeletal muscle cells, where they exhibit a specific citrate carrier that will grab the citrate in the blood and take it inside the cell. In your kidney failure patient, of course, your cortex won't work that well, and so you only have the liver and the skeletal muscles that will remove the citrate at that point. When it enters the cells, it will move to the mitochondria, where there you have another specific carrier that will integrate it into the mitochondria. And this is when it becomes really interesting, actually. Because it enters the the Krebs cycle as citrates. And so the citrates will move to cis-acetate, and move again and lose 2 times 2 CO2s until it reaches oxaloacetate that you see here at the middle left. Then acetyl coenzyme A will bring another acetyl and will form another citrate. You can imagine that if you keep adding up citrate, you will have accumulation of citrate and all the different molecules of this Krebs cycle. So you will have to have other escape mechanisms in order to remove this citrate. And this will be through amino acid genesis, through glutamate, through alpha-ketoglutarate, or aspartate, through oxaloacetate. But you also have neoglucogenesis to glucose through oxaloacetate, and so your glucose can be formed, can be degraded until acetyl, again through glucolysis. And so this is the way that citrate will be removed from your body and will be metabolized. If you don't have that and you have liver impairment, you will see that the citrate inside your blood will start to accumulate bound to calcium. So we'll see, we cannot measure the citrate. We can measure the citrate inside the blood, but it's a very expensive method, and that takes a lot of time, so it's not, it cannot be used in daily clinical practice. So you need to have a surrogate, and a surrogate is the total calcium to ionized calcium ratio. Why the total calcium? Well, because you'll have the bound calcium that is bound to albumin and citrate, but you'll see that the albumin will stay quite stable. Even if you will be adding some albumin, this won't raise a lot. It is only the citrate to calcium ratio that will rise at that point. You also have for your total calcium ionized calcium, so that's why you divide the total calcium by your ionized calcium. However, be aware that it's not a foolproof mechanism. You will see that in some patients, you still have citrate accumulation, although your product is below 2.5, and in some patients, you won't have accumulation, even though your product is above 2.5. So there are other things to consider as well when you're using citrate. And that's your pH. Because your pH, and that's, you see that is in liver impairment, your pH will decrease because you will have an accumulation of citrate as a citrate 3- and citrate 2-, which will cause acidosis. And you also have anaerobe metabolism that will kick in. So you see indeed that when you use this citrate in liver failure patients, your pH will be lower than when you, at the end of your treatment, than when you started, as contrary to normal patients where you have a slight alkalosis. And why is that? And that's my personal point of view. I talked with a lot of chemists about it. Nobody had a real answer. I had to look up books and stuff like that. And so this is my hypothesis, actually, that citrate will inhibit glycolysis. This is known. And if citrate will rise, the glycolysis will be blocked, and then you have anaerobe metabolism, and lactate will be formed. And this idea is supported by this trial where they saw that when they stopped the citrates, when they saw citrate accumulation, you can see here the lactate going up because your anaerobe metabolism will go up because you have citrate accumulation that was diagnosed as a total calcium to ionized calcium. However, when you stop it and change it to heparin, you see that the lactate will go back down again. There can be some bias, I agree. But still, it is good. It supports the hypothesis of anaerobe metabolism. But be aware that this citrate accumulation is detrimentous and is really bad for your patient. And in the same study, they saw that all the patients who had citrate accumulation that were not lost to follow-up died. So you should be aware that is a very important complication. And so you should monitor all your patients where you're giving citrate. Interestingly, it is not all the patients had liver impairments, but all the patients had refractory shock and multiple organ failure. So those are the patients where you should really monitor. Also, of course, also the liver-impaired patient, if you would like to use citrate in those patients, but be aware in those patients in refractory shock and multiple organ failure. And so you can find you can find something that's changing when your citrate starts to accumulate. You'll see that your ionized calcium will start to drop in your systemic blood circulation. And you'll also see that you will need to give more and more calcium systemically to your patient when that happens. You'll also see, of course, that your base excess will drop. And so this will bring me to my last slide about the things we should consider when we are using citrate as an anticoagulant. First of all, use citrates. I think it is a good anticoagulant. You have less complications. You extend your filter lifetime. However, monitor your calcium inside your extracorporeal blood circuit and make sure that it's below 0.4. We have in our hospital the policy to try to be in range of 0.25 and 0.35, so we have a little bit of margin there. Then monitor your systemic calcium, because you will lose a lot of calcium inside your effluent, but monitor it also because it is a starting sign that something is going wrong when your citrate is not metabolized. And you will see this indeed in liver-impaired patients, but you will see it especially in those patients in refractory shock and in multiple organ failure. And so in order to detect it, measure also your total calcium to ionized calcium ratio, measure your pH, measure your lactate, measure your calcium substitution, and measure your base excess, and do it repeatedly. So for those who have been paying attention, I only mentioned 9 things. And the 10th thing is the effect on energy metabolism that citrate has. But this will be for the talk in 1 hour after this. So I thank you for your attention. Happy to take some questions.
Thank you for this clear presentation on citrate. Questions from the audience, please. Microphone here in the first line.
Congratulations for your presentation. I agree that citrate prolongs the filter life, and it works beautifully. Maybe in some really shocked patients it can be tricky, and liver failure depends on if it's not really severe, you can use it too quite safely. But do you have the impression that it can promote having our patient too long on CRRT in some cases?
That's a very interesting question, and we talk a lot about it, especially on a metabolic point of view, because for me it seems that it will stimulate actually metabolism, amino acid production, and neoglucogenesis. So it seems like something that stimulates and will actually be able to make sure that you won't have this problem of prolonged CRT needs, but I don't have any evidence about this answer. We mostly use citrate. We don't use unfractionated heparin, only in those shock patients. We have some disagreement with some colleagues. I try to sometimes a little bit if it's not too much of a shock, but if lactate is above 10, we usually don't use it.
When the filter clots, it's a moment you think if you're going to continue your patient on CRT or you can stop. That's a moment I think we all here think about that when the filter clots. But with citrate, you don't have filter clotting. So maybe...
We do have clotting. I think most of our filter, for us, if I look at our patients, we only do CVVH. Maybe we should try to do CVHD also, or CVHDF. But I think I have the impression that our filter lifespan will be about 4 to 5 days only. So, yeah.
Okay, there is another question in the middle of the floor, please. Microphone.
Hello, thank you for your presentation. May I ask, in your practice, how often do you take calcium levels or ionized calcium level in a practical view in order to see that you have to stop citrate or not?
When we start, our current protocol says every 2 or every 4 hours. And then we repeat it until it's stabilized, and then it's every 6 hours that we perform analysis of it.
Any other question? Okay. Thank you.
And we move on with Stéphane Gaudry from Pérez, how to reduce the risk of renal replacement therapy-induced kidney injury. Stéphane.
Thank you very much, ladies and gentlemen, dear moderator. I would like to thank the scientific committee for the invitation. So, how to reduce the risk of renal replacement therapy-induced kidney injury? That's the question. Also called artificial kidney-induced kidney injury for AKIKI. I received grant from French Ministry of Health, but I have no other conflict of interest regarding AKI or renal replacement therapy. So we will start to look at the argument in favor of the concept of RRT-induced kidney injury and discuss the different mechanisms involved in this concept. And then we will ask how to reduce the risk of RRT-induced kidney injury. So as you know, acute kidney injury and chronic kidney disease are two interconnected syndromes, and possibly renal replacement therapy may be a risk for chronic kidney disease. In this interesting study, you can see that RRT-treated AKI is a long-term risk for end-stage kidney disease. So Rinaldo Bellomo showed you this very important paper. As you see, it's a whole concept in 71. And the author of the paper say that hemodialysis may contribute to the prolongation of renal failure because they observe on the biopsy that there is still fresh tubular necrosis in these patients who had an initial ischemic insult 3 weeks before. There are also this paper, there's also this paper, an interesting paper from Nicolas Leroll, which include patients under septic shock. And you can see here again that tubular lesions were more severe and more frequent in patients who receive renal replacement therapy. So what are the involved mechanisms? I choose 3 mechanisms: the modification of renal hemodynamics, the activation of platelets and neutrophils through the contacts with the membrane, and the removal of molecules that are potentially crucial for tubule regeneration. So the first mechanism is the renal hemodynamics. We know that hypotension episodes during the session are very frequent, as is shown in this study in 2008, the ATN study. You can see that hypertension requiring vasopressor support is a frequent situation. And the question is, may these hypotension episodes lead to an alteration of blood renal flow? And the response is probably yes. When you look at this animal model study, during AKI recovery, kidneys are more susceptible to other kidney stress, and notably hemodynamics. And in this study, there is 2 groups of rats, one no AKI group and one AKI group. And when there is a drop in blood pressure after the AKI, there is a very important reduction in renal blood flow in the rats who had acute kidney injury. Here again, this paper was described by Rinaldo. In this paper, there is a decreased renal perfusion during chronic hemodialysis. The investigator used tomography perfusion imaging to perform the study, and they compare standard and cool condition. And as you can see, decreased renal perfusion is frequent during hemodialysis, and it is correlated with ultrafiltration, with more myocardial sedation, and it is attenuated by cold dialysate. Okay, the second potential mechanism is the activation of platelets and neutrophils through the contact with the membrane. Here again, this is a very old study in the 80s in the New England Journal of Medicine. The problem was that at this time, the leukopenia was very frequent after renal replacement therapy initiation. And they show that there is a complement activation by the dialysis membrane. At this time, it was cellophane membranes. And there is also granulocyte aggregation, including granulocyte aggregation in the lung. And this study performed in 91 suggests that this complement activation that occurs during dialysis with cuprophane membrane may be a factor in the delayed resolution of acute renal failure. So probably you know this first important randomized control trial comparing different membranes, one polymethyl metacrylate membranes, which was considered more biocompatible, and they were compared with the previous membrane, the cuprophane membrane. And you can see that there is a signal, the biocompatible membrane, was associated with improved recovery of renal function. Okay, but if we look at the Cochrane review, this meta-analysis, the conclusion is that there is no demonstrable clinical advantage to the use of biocompatible membrane versus bio-incompatible membrane in patients with acute kidney injury that require intermittent hemodialysis. So even if you use very biocompatible membrane, it's never strictly biocompatible. Okay, the third mechanism is the removal of potential crucial molecule for the tubule regeneration. And there is a very important study on this question performed by the team of Samir Parich, which showed that exogenous vitamin B3, in this case it was nicotinamide, this vitamin may improve renal function in two acute kidney injury model mice, a post-ischemic acute kidney injury model and a cisplatin-induced acute kidney injury. And the problem is that nicotinamide is a very, very small molecule which can be very easily removed by renal replacement therapy. So we decide to analyze this question and explore mechanisms of artificial kidney-induced kidney injury, and we perform this model of hemodialysis in rats after acute kidney injury in our lab, and I hope that I will show you the definitive results next year. But the question is how to reduce the risk. The first is to apply delayed renal replacement therapy initiation strategy, because during recovery from AKI, the kidney are more susceptible for further injury, and possibly the early renal replacement therapy may act as a second hit on kidney function. In the Akiki trial, we randomized early and delayed renal replacement therapy strategy. And in this trial, one result is that almost 50% of patients never receive renal replacement therapy at the end of the study, which is a very important difference between early and delayed renal replacement therapy. But we did not observe any survival difference between the two groups. However, a secondary endpoint was the renal function recovery. And renal function recovery was estimated as like adequate urine output with no need for renal replacement therapy. And you can see here that the delayed group was associated with a more rapid renal function recovery. But at this time, it was just an hypothesis. So we performed a post-hoc analysis of the Akiki trial to assess this question. Here you can see the cumulative urine output during the first 2 days after the randomization. This is almost 1,900 milliliters in the delayed group compared to almost 1,000 milliliters in the early group. This is a large difference, and this difference was independently associated with renal function recovery. But now look at the ultrafiltration, the cumulative ultrafiltration during the first 2 days. It was very small in the delayed group, 200 milliliters compared to 800 milliliters in the early group. But if you cumulate urine output and your ultrafiltration, you have the cumulative fluid output. And here, there is no difference. And also, the fluid balance did not differ according to renal replacement therapy initiation strategy. But in the delayed group, the kidney does job. In the early group, this is a machine. And this is why we highlight the emergence of this new concept of artificial kidney-induced kidney injury. And this concept was confirmed in the very large multi-center international randomized control trial, START-AKI, the Canadian trial. In this study, which compared the same group of patients, early and delayed renal replacement therapy, you can see that in the early strategy, 10% of patients were dependent from renal replacement therapy after 90 days compared to 6% in the delay. And 90 days, this is a very important limit because this is the limit between acute renal disease and chronic kidney disease. So these results show that the early renal replacement therapy strategy is associated with an increased risk of chronic kidney disease. So the second point to reduce the risk is do not use intensive renal replacement therapy. I show you again this very important trial on intensity, the ATN trial. You can see here that the intensive strategy was associated with more hypertensive episodes requiring vasopressor support. And in a post-hoc analysis of the same study, the author concluded that more intensive modality were associated with a greater reduction in urine output during the first 7 days. And here again, another post-hoc analysis of ATN in a subgroup of patients of hemodynamically stable patients. Intensive intermittent hemodialysis was associated with impaired renal recovery after 28 days. And finally, in this meta-analysis, including all the study on this question, they conclude that in severe AKI patients, higher intensity does not affect mortality, but appears to delay renal recovery. The third point is apply the good setting for renal replacement therapy. And Rinaldo also discussed this point, but just have a look on the very simple intervention for intermittent hemodialysis to improve the tolerance. Isovolemic initiation, reduced dialysate temperature, reduced dialysate flow rate, and use conservative ultrafiltration. And if you use this very simple intervention, you will improve the hemodynamic tolerance. This is the evidence for this. A very old study, but very important study, which show that if you use this intervention, there is a very important reduction in blood pressure drop during the session. So the conclusion is that in ICU, intermittent hemodialysis should not be prescribed as in chronic dialysis unit. That's why in France, the intensivists prescribe the intermittent hemodialysis. This is not the nephrologist. But here again, I think that I disagree with Rinaldo on the question of modalities. I think that there is also a problem with continue. And he performed this very important post-hoc analysis of Renal 3 years ago. And he showed that the net ultrafiltration rate, which is the volume of fluids removed per hour adjusted for body weight, when this net ultrafiltration rate is high, this is associated with lower survival. So we have to be aware of this kind of study to set hemodialysis. And just to conclude on this study, I think that treat fluid overload is never an emergency. Or sometimes, but for me, it's never in the ICU. Okay. Now, the third point, the last point, the fourth point, vitamin B3 supplementation. I decided to show you this important trial on the question. This is a trial, a pilot randomized control trial that was published in this paper in Nature Medicine in 2018 by the team of Samir Parich. And in this study, they show that nicotinamide, which is vitamin B3 administration, was associated with better estimated renal function, as you can see on the serum creatinine concentration after cardiac surgery, and even, as you can see, in the occurrence of acute kidney injury after cardiac surgery. So to summarize my talk, I have 30 seconds. This is the emergence of a new, but this is the re-emergence of a too often forgotten concept, the artificial kidney-induced kidney injury, which may be explained by the modification of renal hemodynamics by the activation of platelets and neutrophils through the contact with the membrane, and possibly the removal of molecules that are crucial for renal tubule regeneration, and how to protect the kidney and how to protect my patients from further injury. First, do not jump, rush on renal replacement therapy. Second, intensive RRT modalities prove deleterious. Third point, the least intensive is no renal replacement therapy. So use delayed replacement therapy strategy. Apply the good setting for renal replacement therapy, and possibly there is an interesting place for vitamin B3 supplementation. But here, I think that we need randomized control trial. And I disagree with Claudio Ronco. I think that the intervention in the ICU should be assessed with randomized control trial. Thank you very much for your attention.
Well, thank you very much for that great overview. Is there questions? Yes, please. Number one, number two, and we need a microphone. So you don't give it to your patients now?
Sorry?
You don't give it to your patients?
Vitamin B3?
Yes.
No. At this time, no. But I think we have to assess the efficacy in a randomized control trial.
Okay.
Yeah. But there are some ongoing randomized control trial on septic shock, the VITA-KEY trial. They plan to include 300 patients, and they have included 100 patients, so we will have some data to discuss next year.
Yep. Okay.
Congratulations, Stéphane, for your talk. Do you think that intensity renal therapy that is deleterious for renal recovery could be related with, because we're talking about trials where a lot of convection was done at that time. Do you think that convection could play a role there? I know you're intermittent and you don't care if it's, but do you think it could play a role? I mean, you're removing things that you don't know what you're really removing, maybe vitamins too?
Yeah, you're right, maybe. But I don't know exactly. And but vitamin is very, very small, so you can easily remove with hemodialysis, intermittent hemodialysis too. But we don't know exactly, but probably it's the number of hypotension episodes during the session. Possibly it's the time you spent in the contact with the membrane. I don't know. And the other hypothesis is very interesting, but it's impossible to conclude. That's why I think we have to come back to the acute kidney injury animal models to assess this question.
Okay.
Thank you. Very interesting talk indeed. So do you never use intensive renal replacement therapy? Because in our center, when we have a patient that's admitted with high lactatemia, refractory shock, difficult to treat with a low pH, and with a lot of vasoconstrictors, we usually try to induce intensive renal replacement therapy to remove the lactate so we can diminish a little bit the vasopressors and hopefully resuscitate him better like that.
So that's an interesting question. In my ICU, when a patient had septic shock, very severe septic shock, I prefer do not use extracorporeal resuscitation. So do not use renal replacement therapy at first. I prefer use bicarbonate infusion if you have a problem with the pH. You have a lot of study on this question, and it's safe, and it's possibly efficient for patients with severe acute kidney injury. This is a BICAR-ICU trial performed by Samir Jaber. And if you really need to start Okay, no problem. You have to continue. During the first 2 days, you can increase slightly the intensity, but I think it's not necessary. Probably 1 or 2 patients in a month.
Thank you very much for your presentation. I'm a big fan, and although I absolutely have the same opinion on the timing of renal replacement therapy, but I have a big issue about the numbers of the patient which were excluded from the trial. And I'm wondering, in START AKI, it's even more, I guess, and I'm wondering if you can explorate all these numbers and findings on the everyday routine in clinical practice. This is first comment, and the other one is that my personal opinion is that we are very restrictive with the doses of the dialysis doses on the continuous renal replacement therapy, because it's for years haven't been questioned so far. We start with the 20 to 25, although we know that the off-filter time is way less than it used to be for years. Now with citrate anticoagulation, we are way better off. So we might probably move to the other concept that, say, after 3 days, we have to decrease or maybe stop the therapy at all.
So thank you. 2 very interesting questions. So the first, the patient excluded from the large randomized control trial, AKIKI, DLIC, or START AKI. You're right, but it's the same in other randomized control trial. If you look at the reason for the exclusion or non-inclusion, it was because of life-threatening condition, like severe refractory hyperkalemia, severe refractory acidosis, or sometimes drug intoxication. So there is a lot of indication. You're right, we can go back to the observational, but I think we have a lot of data with randomized. Now we have to move to from this randomized control trial to personalization of initiation, and we work on this question. Tomorrow I will show you some results about this question. For the second question, you're right, because now we use RT like with a delayed strategy. Probably sometimes you start after 2 days or after 3 days, like Lui Forni say, there is a kind of heterogeneity. But we have changed our practice. And we have to ask the question of the modalities, because the studies, the trials which were performed on modalities 20 years ago or 15 years ago, they include patients who never need renal replacement therapy. That's the problem. And that's why we have to reconfirm this problem. And that's why our team will perform a study comparing intermittent and continuous renal replacement therapy in ICU patients, even in context of hemodynamic instability. I think there is no difference, and we will start next month a non-inferiority trial. And we will discuss this point also with a colleague tomorrow.
Okay, thank you very much for this talk. Let's move now to a hot topic that is optimal fluid management, and the talk will be given by Marlies Ostermann. Welcome.
Thank you very much for the kind introduction, and it's a great honor to contribute to this session, and I will undoubtedly add some controversy to the presentations and discussions. Here are my disclosures, and as you can see, I have received research funding from Baxter and Fresenius, and would like to confirm that this has not influenced what I'm going to say in the next 15 minutes. So to me, clearly optimal fluid management is essential for anybody, whether they need renal replacement therapy or not. But I put it to you that the renal replacement therapy devices actually help us to achieve optimal fluid management, because you can essentially do what you need to do. You can the machines allow you to remove excess fluid if patients are fluid overloaded. The machines allow you to keep the patient euvolemic, if that is your goal, and either not remove any fluid or just remove the fluid that needs to be removed to compensate for intake. Or, again, it allows you to give the necessary fluids in patients who can tolerate fluid administration or may even be hypovolemic. And the key factor for me, whether to remove fluid or not to remove fluid, but really the key factor to keep patients euvolemic is the fluid status of the patient and what I'm trying to achieve. Now, I still believe that fluid removal is one of the key indicators for renal replacement therapy. It's one of the most common reasons why clinicians start renal replacement therapy, because we all know that fluid overload is harmful. It's also clear that fluid overload is harmful to intensive care patients, whether they need renal replacement therapy and have acute kidney injury or not. Fluid overload is also harmful in patients who are on renal replacement therapy, and the risk of dying is directly linked to the severity of fluid overload and the duration of fluid overload. Not only the risk of mortality is higher in patients who are fluid overloaded, these patients also have a higher risk of longer-term complications. So in this study, the team analyzed the data of 481 patients who had renal replacement therapy for acute kidney injury. And they looked at the impact of fluid overload, and in this case, fluid overload was simply defined as the difference as the weight gain between admission to the intensive care unit and the start of renal replacement therapy. And then they distinguished arbitrarily between patients who had gained less than 10% of their body weight and patients who had gained more than 10% of their body weight. And then they looked at longer-term outcomes, in this case, MAKE 90, which is a composite describing either mortality or renal replacement therapy dependence or inability to recover kidney function to 50% of baseline renal function by day 90. And as you can see here, patients who were more fluid overloaded at the time of initiation of renal replacement therapy, so a fluid overload of more than 10%, had a higher risk of an adverse event at 90 days. They had a higher risk of not leaving hospital alive, and they had stayed on the ventilator for longer. They had less ventilator-free days. So being fluid overloaded at the time of initiation of renal replacement therapy has a long-term impact. And the impact is directly related to the degree of fluid overload as shown here. So avoiding fluid overload and managing fluid overload is essential. Now, Professor Bellomo's renal study also showed that fluid overload on renal replacement therapy remains a problem. And as you can see here in the sub-analysis of the renal study, which was a dosing trial, they clearly showed that survivors ended up with a lower fluid balance throughout the whole period whilst on renal replacement therapy. Non-survivors tended to have a higher fluid balance. Now, this is only an observation. It doesn't tell us why this happened, and we may just say, well, it's harder to remove fluid in patients when they're sicker and have a higher risk of dying, and that may well be the case. But at the same time, it also illustrates the problem that it may just be very difficult to remove fluid or to get the fluid removal prescription right in these patients. And this brings me to the general principle of fluid removal. So when we connect patients to any form of extracorporeal device with the aim to remove fluid, then obviously we can only remove fluid from the vascular space. Now, the patients are often overloaded everywhere, intra and extravascularly. So we can remove fluid from the vascular space, and it appears the maximum capillary refill rate is about 10 mL per kilo per hour. So this means the blood vessels, the tissues will then shift fluid from the extravascular space back into the vascular space to compensate for fluid removal. And if this works well, then we can remove fluid without any hemodynamic instability. And clearly our aim with any form of extracorporeal fluid removal would be to remove fluid at a rate as the patient can tolerate. So at a rate that is not higher than the physiologic refill rate. Now, the issue again is when people are sick in the intensive care unit, the normal vascular physiology is disturbed, and they often have endothelial dysfunction and increased vascular permeability. So it's much harder to shift fluid from extra back into the vascular space. In fact, often they leak out fluid. And that's the reason why there is an increased risk of hemodynamic instability when we try to remove fluid in these patients who are very sick with severe increased vascular permeability and endothelial dysfunction. And the risk of instability, as shown in various studies which we heard in the previous talk, is higher if we remove fluids too fast, if we remove fluids beyond the euvolemic state, if we try to remove fluid in patients who are very vasoplegic, and in patients with an increased endovascular permeability. The risk is also increased in patients who have additional risk factors. So for instance, cardiac dysfunction or a low oncotic intravascular pressure. And that's why it's important to individualize the prescription of fluid removal in these sick patients. And this is the graph as it was created in response to an analysis of existing data, and Professor Gaudry showed some of the data looking at different ultrafiltration rates. So on the one hand, we want to minimize and shorten the period of fluid overload because, as I've already shown you, duration of fluid overload is associated with a bad outcome. So we want to keep it as short as possible and get the fluid off as quickly as possible. And at the same time, we know that this could be associated with an increased risk of hemodynamic instability. And more importantly, if hemodynamic instability occurs, then this would potentially be harmful to all the organs, including the kidneys. And we've just heard the concept of artificial kidney injury. Because clearly, in the case of hemodynamic instability in somebody with acute kidney injury, the chances of renal recovery are reduced. But it's not just the kidneys which may come to harm in case of hemodynamic instability, it's also the brain, the gut, and clearly the heart. So hemodynamic instability during fluid removal, during renal replacement therapy, is not good for any of these organs. So that needs to be avoided. At the same time, we need to shorten the period of fluid overload and get the balance right. So how can we get the balance right? We can only get the balance right if we get our prescription of fluid removal right. So set the perfect optimal fluid removal target and continue to watch the patient and monitor the patient carefully. And that's easily said, but in clinical practice, it's much harder. And certainly when colleagues looked at the achievement and success of fluid prescriptions, they noted, as shown in this paper, that non-survivors had a much higher incidence of the fluid prescription not being met in clinical practice. So they called this a fluid balance gap, essentially, which described the difference between the prescribed fluid balance target and what was actually achieved. And the gap was much higher in patients who subsequently didn't survive. And it's either because the prescription was simply wrong and was not adjusted to the patient's needs, or it was just difficult for the team at the bedside to achieve this fluid balance, or the patient just changed because the patient clearly is in a dynamic situation, and what we aim to do in the morning may not be achievable in the afternoon when things change. And the gap, this so-called gap between what they had aimed to do and what was actually achieved, was directly, again, correlated with a poor outcome. But ultimately, at the bedside, at the moment, that's what we do. We prescribe fluid removal, and we hope that this is possible and achievable for the team at the bedside. Now, we also, in our unit, tried to explore this in more detail and tried to find out why some patients just remained fluid overloaded whilst on CRRT. We analyzed 820 patients who were on renal replacement therapy, and again showed, as many others had shown before, that survivors tended to have a lower cumulative fluid balance throughout the whole period on renal replacement therapy. And the other way around, non-survivors just had more fluid on board. Non-survivors also tended to, or survivors who were able to achieve a negative fluid balance, and this was not possible on average in most people who subsequently died. And as I've already alluded to, it may just be that these patients were sicker, that it wasn't possible, or that we did something wrong. And I think it's a combination probably of both, because in a multivariable analysis where we try to identify the factors that contributed to the inability to get patients to a negative fluid balance, as you can see here, it was severity of illness that contributed. It was the daily noradrenaline dose as an important factor, but it was also our prescription. And more importantly, it turned out that there were patients in this database for whom the fluid balance had not been set for several days in a row. So clinicians not setting a fluid balance target, that means that the team at the bedside clearly doesn't know how much fluid to remove, and it is much easier just to remove less because nobody wants to risk hemodynamic instability. And so there was a clear link between the proportion of days when a prescription was done and a fluid balance was set and the risk of not achieving the fluid balance. So part of the issues are that patients are just sick, and part of the issues, I believe, are that it is hard for us to get the prescription right, and occasionally we may not even set a fluid balance target. Now, coming to the end, clearly none of us like hemodynamic instability on renal replacement therapy, and certainly not the nurses. They are usually at the front line dealing with this. Is there anything we could do to predict hemodynamic instability? At the moment, we don't have good tests. Now, Professor Monet and Professor Terboul argue that the passive leg raising test may help us. And so they use the passive leg raising test, which is obviously a test looking for fluid responsiveness, to identify those patients who may not tolerate fluid removal. So the presence of a preload dependence and a presence of signs of fluid responsiveness indicated that these were patients who were unlikely to tolerate fluid removal. It's a very informative test. I think at the moment it may not be practical for us to do this every day in everybody who's on renal replacement therapy, but it is at least a test which can help us, may help us. If we knew that somebody was developing hemodynamic instability, then here's a list similar to the list shown earlier by Professor Gaudry and Professor Bellomo, that are little tricks to help us or help the patient to tolerate fluid removal a little bit better. So reducing the rate, keeping the dialysate a bit cooler, and reassessing the patient on a regular basis. And then lastly, it may also be possible that there are some additional adjuncts, and certainly Professor Mehta in San Diego suggested in this trial that albumin infusion, albumin supplementation may have a role in patients who are hypoalbuminemic and need fluid removal. So they randomized patients who needed renal replacement therapy and fluid removal and had hypoalbuminemia as defined by an albumin of less than 3 grams per deciliter or 30 grams, and randomized them to albumin versus a saline bolus at the beginning of renal replacement therapy. As you can see here, the patients who received albumin essentially had less episodes of hypotension, and they also had less episodes where ultrafiltration had to be discontinued. It's a relatively small randomized control trial, but physiologically, clearly it fits. So they raised the intravascular oncotic pressure and made it easier to remove fluid. And this may be a little trick. So coming to the end of this, in summary, I believe that renal replacement therapy is a very good tool to achieve optimal fluid balance. The ideal fluid state is a euvolemic state, this very clear, no single organ likes to be either hypovolemic or hypervolemic. If patients on renal replacement therapy are hypovolemic, then they need some fluids. That's straightforward. If they are overloaded, then the aim would be to get fluid off as quickly, but also as safely as possible. There may be some adjuncts necessary, but to keep patients in this euvolemic state, regular assessment and adjustment of the fluid removal rate is essential. Thank you for your attention.
Thank you for this fantastic overview on the topic that is open for discussion. Questions from the floor? Yeah, microphone, please.
Hello. Thank you for a great presentation, great overview. In the study you did with Dr. Hall, it seemed like the cumulative fluid balance at the start of dialysis didn't have an influence in the multivariate analysis. Is it because there was very little spread on that factor, as you're probably quite restrictive in your fluid management, or do you think it doesn't really matter?
So I do think it matters, the cumulative. So for a start, I want to say I always struggle with the concept of using fluid balance as an indicator of fluid overload, because that's the best we can do. But if you and me were both admitted to the intensive care unit, and I had congestive heart failure, and you had had cholera and had lost 3 liters of fluid and had terrible diarrhea, and we both got 2 liters of fluid, and we were both 2 liters positive, I would be completely overloaded because I was overloaded before, and you would still be hypovolemic. And despite, on paper, we would have gained, I don't know, 3% in our body weight. So the tricky part is that these figures which we use are actually not the best indicator, the best we can do, but then they don't necessarily mean that the person is fluid overloaded. So in our study, in our analysis, community fluid balance at time of initiation was not related, but other studies have shown this.
Could you comment on the use of the potential use of echocardiography for guiding fluid removal, please?
Yeah, perfect. Yeah, so I do believe that if we could, then it would be great if we could monitor patients on CRRT continuously. So we remove fluid and we often leave it to the nurses, and we don't monitor things. And a regular assessment by echocardiography would be perfect. But again, it would be a snapshot at one time. But if you could do continuous echocardiography monitoring, that would be wonderful, because then you avoid what Professor Gaudry was talking about, artificial kidney injury and harm from renal replacement therapy.
Okay, thank you.
Well, and we are back to Joop Jonckheer, and he's talking about optimal feeding.
Thank you very much. First of all, I must say that I must stay humble here, because there are a lot of experts here in the room, so I hope I will not disappoint them. So we'll talk about nutrition, and when we're providing nutrition in our patients in the ICU, we first have to meet our caloric targets. And we will talk about the energy-containing molecules, for which we will giving carbohydrates and lipids, but also proteins who contain energy, but will be used to be integrated into the muscles. Then there's also the molecules that will be used for the different processes that are needed inside the cells, like the vitamins and the trace elements. Other way around, sorry. And so we'll first start with the energy. So how should we adapt actually nutrition during CRT? Because I'm not going to talk about the ESPEN guidelines in the general ICU population, but we're going to talk about the specific CRT population. And so for estimation of energy expenditure, we know that you should perform indirect calorimetry. You should measure your energy expenditure. Because if you measured it and don't use a predictive equation, your mortality will be lower. And if then you will be using isocaloric feeding as compared to hypocaloric feeding, once your patient is stable, of course, well, then you will have also a better outcome and better mortality. Why is that? Well, it is because the predictive equations are inaccurate. And you see here in this paper, you see the Harris-Benedict model that has been used against the energy expenditure measured by indirect calorimetry. And you see that if you would use the energy expenditure predicted by the Harris-Benedict model, you will have either overfeeding, but also underfeeding. And we know that this is deleterious for a patient. They tried to build a better model, and you must say indeed that the correlation, the R, was better there. But if you look at the single numbers, you see that you still have a lot of patients with more energy expenditure and less energy expenditure. And for a general point of view, you'll be spot on, but for the individual patient, these are the patients that you will let down and not provide optimal feeding, and so you will have a lower mortality and morbidity. And this is because there are a lot of factors that will that will change the energy metabolism. But to measure the energy metabolism, you have to have, there are certain conditions that should be met. First of all, your patient should be stable. But when you're performing CRRT, well, usually at a certain time, your patients are even more stable than when you're not performing CRRT. The temperature is lower, the temperature is constant, your hemodynamic support goes better, etc., etc. The second condition is that you don't have CO2 or oxygen loss. And so we measured in our patients the CO2 loss that is induced in the effluent, but also in the little deaeration chamber. The deaeration chamber was close to nothing, and in the effluent, both as bicarbonate and as CO2, we saw that we taking the bicarbonate that you will be giving as pre-dilution and post-dilution, we saw that the net effect was max in high-dose CVVH 3% of the VCO2. So you can use indirect calorimetry during CRRT and during CVVH, at least according to our study. And so then we compared, we looked at what the resting energy expenditure was, and we looked in different conditions how this energy expenditure evolved. And so patients started with citrates, and then we removed the citrate and started with sodium chloride pre-dilution. And we saw at that moment that the energy expenditure went down. It went down from 330 kcals, which was statistically significant in our study. Why is that? And this is where I come back from a previous talk. It is because you will stimulate anabolism, and this costs energy. You will go from alpha-ketoglutarate to glutamate, as I told you before, and from oxaloacetate to aspartate, and from oxaloacetate back to glucose, and to avoid an overload of citrate and other molecules that are in this Krebs cycle. So this is our hypothesis why the resting energy expenditure was lower when we stopped citrate. So now you have your resting energy expenditure, and you've measured it because you want to provide the best help for your patient. You measured it with indirect calorimetry. But then you have your number you will need to feed your patient. And so you will need to take account of all the non-nutritional calories that are exchanged, the bioenergetic balance, if you want to, of your machine. You will be giving citrates, but you'll be also removing glucose, lactate, and amino acids. We don't use fluids anymore that contain glucose and lactate, so we don't take this into consideration into our formula. And we know that it can be quite substantial with from older studies, and this can be up to 512 kcal in these studies. Other studies have shown numbers up to 1,000 kcals that are added to the patient, but this was when fluids were used that still contained glucose. So we did a retrospective analysis of the previous trial, and we looked during in our patient how much calories we would be giving the patient. And so for citrate, this was about 736 kcals a day that we would give to a patient that he need to metabolize. We were losing 222 kcals due to glucose, and lactate was only of a minor importance there. This meant that compared to the energy expenditure, this was about 40% of the energy expenditure that could be given as citrate, but was compensated for 12% of glucose in low-dose CVVH. And this changed, and you can say it's 40%, yeah, but you see a wide range. You see that it can go, for the citrate, it can go from 26 up to 69%. So you see here that the range is quite big, and you cannot generalize for all your CRRT patients. The same is true for glucose and lactate, who's still not so important. If we put this all into this complicated graph, I must admit, but I'll walk you through it. At the top, you see the black line, and this is the energy expenditure that you have measured. And we computed against that line the percentage of energy that will be provided as citrate, lactate, or lost as glucose. And we put this all together, you have the bioenergetic balance. If you integrate this into the progressive nutrition therapy that we should give as the ESPEN guidelines tell us to do, you see that you will either underfeed or overfeed at the start, but especially after a while, you'll see that you largely overfeed your patient if you don't take this into consideration. And we know from studies that overfeeding your patient will cause harm, but underfeeding your patients also. So you need to be spot on. And that's why we developed in our center a formula in Excel where we're putting all the different settings of the CRRT machine, whether it's using citrate or not, what the flow is of the pre-dilution, the blood flow, the efferent dose, what the 24 hours glycemia was, but also the 24 lactatemia was. And then it calculates the caloric, the bioenergetic balance of our therapy. And you see here at the top line, I don't know if you can see it, you see that you can either get 586 kcal in these patients here that you see, but it can also go to minus 577 kcals if you're not giving citrate as pre-dilution. So I would advocate to build this calculator. I'm trying to integrate it into our electronic file so that we have an automatic calculation every day of this bioenergetic balance of our patients. I know that it is not proven that this, if you take this into consideration, you will have a better effect. It looks logical, but therefore we would like to make an interventional randomized controlled trial to prove these points. These physiological, logical points. We'll talk then about the proteins, because those are also important, and we know that we'll lose the proteins as amino acids and small proteins, and this can go from 13 grams up to 53 grams. But what is even more complicated in this patient is that and you see here that indeed when you're giving more protein, so more than 1.2 grams per kilograms per day, this is a retrospective analysis, be aware, you'll see that your hospital mortality, your ICU mortality will be lower in a non-septic patient as compared to the patients who are receiving less than 1.2 grams per kilogram per day. I put a kilogram too much there, I think. But it's not only about the dose of the proteins, it's also about the quality of the amino acids. You see here this graph about the types of amino acids that are removed through your efferent. I've noted the essential amino acids in red. And you see that those levels, those are not the amino acids that are removed the most. No, you see here that the amino acids that are removed the most are those that are non-essential. And so it could be that those non-essential amino acids become essential at that point because your body cannot cope with the losses that you have there. And so I think we should have more CRT-specific solutions with specific amino acids content. Then we go to an area of more uncertainty, and that's the area of trace elements and vitamins. We know that stuff is happening. We know that the vitamins are lost, and our previous colleague, Dr. Gaudry, already talked about vitamin B3, but we see that the levels that are lost in the effluent go down from your folic acid and also your vitamin B6, and this is because the plasma levels also go down in those patients. What we performed, we measured also in our center together with Professor Douala, who initiated this study. We saw actually that in our center we did quite well, and our thiamine levels were quite high, as were our folic acids. We had a problem with our fat-soluble vitamins. We know that we're losing vitamin C, but I'm not going to talk about vitamin C. We can talk a whole day about vitamin C, the pros, the cons, etc. We know that we lose about 68 milligrams a day. If you need to replenish it, you will probably need to give that amount extra. How much you should give in those patients, that's a completely total discussion due to the antioxidant effects, etc., etc. And I'll not go into details for the sake of time. This study also showed that these vitamin C levels were low in 80% of the cases, as well as were the other vitamins. And you see that all these vitamin levels change depending on in which center you are measuring this. Sorry, I will go back. And this, oh, okay, it's okay. And this finding has also been shown by Wischmeyer's group, who published in 2022 also very low levels of vitamin C and vitamin B in patients under CRRT. And then we go into the trace elements problem. The trace elements, they go everywhere. The only thing that's quite substantial is that the copper levels are low, and also been shown to be low in the last analysis by Wischmeyer and his group, this publication in 2022. But what is happening with our trace elements is they are, some are removed and some are added. And this depends on the kind of fluids that you're using. And we don't actually know what the levels are in the fluids, because they calculated the levels, and there was in the, can I go to the previous slide, please? Okay, here we go. You see here that the levels depend on if you're using bicarbonate solution or lactate solution. The zinc values can differ there, but we know that the firms who produce these fluids actually have a range in which these trace elements should be, but we don't really know what the value is exactly, and this will depend also on the primary material that is used to build these effluent fluids. And so I think more regulation or more knowledge about that should be known. And so also you see here that the percentage of deficiencies in those patients as the trace elements are removed into the effluent, it is quite substantial. So if I can conclude my presentation, I would say use indirect calorimetry to guide your energy delivery. You should calculate your losses of citrate and glucose, and you can integrate this into your electronic file. It is quite easy. If you can do it in Excel, I'm sure you guys, your IT guys can do it too. Then you should give proteins, and probably more proteins than in regular population, with specific CRRT solutions that until now still do not exist, but I think we should work with the pharmaceutical companies to build some. And you should also give more proteins and at least more than 1.2 grams per kilograms per day. For the vitamins, we don't know, but measure it in your center, measure it in a few patients that you are receiving CRRT, and you'll see that you have deficiencies, but you'll also see that some patients will be right. And based on what you will find in your center, you can adapt your clinical practice. For the trace elements, I'm afraid I cannot give you any advice. I thank you for your presentation. I would thank also the team from nutrition that we worked closely together with in our center, Professor Douala, who was also my promoter for my PhD last year.
Well, thank you for that overview, and it's open for discussion. So who's handling actually the nutrition balancing in your unit? You have extra personnel, or you do that on your own? And how would you envision this on a regular ICU somewhere in Europe?
So in our center, it started with Professor De Waala, who installed the rounds by the dietitians. So we have 2 dietitians that each have 12 beds, and they check every day how nutrition is going, how the patient is going, electronically. And then they go to the patients and to the physician in the ICU, and they talk with the physician and propose a treatment. We try to have weekly rounds together with our dietitians to discuss the difficult patients, the long-term ICU patients, and they can always come to her or to me or to Professor De Waala or to me when they have difficult questions about patients about the difficult cases actually.
One question. How often do you measure vitamins or trace elements in your patients regularly? Weekly or?
Well, we are building a protocol for the moment where for all the patients, and especially the long-term ICU patients, we measure them weekly. Sadly, we cannot measure all of the vitamins because it's not reimbursed, and so we would have a problem or with the direction of the hospital or with the lab. So there are only some vitamins that we will be measured, but I think there will be an indication of what's happening in your patient. And if you see really deficiencies, you can either try to measure all of them in these patients or just supplement, replenish actually in those patients that have deficiencies.
You never supplement without measuring? You never supplement without measuring?
Well, we do supplement. So what we do in our enteral, when they have enteral nutrition, normally they have enough vitamins and trace elements. However, when we're giving and providing parenteral nutrition, we would add 1 vial of commercially available trace element and vitamins inside the parenteral bag. Yes.
Okay, thank you very much. It's time for the almost last session. Is when to stop renal replacement therapy, and the talk will be given by Professor Achim Jörres. Welcome.
Thank you very much for that kind introduction. Yeah, when do we stop therapy, and how do we stop? Of course, there's always more avenues towards the goal. So we could simply stop. So we discontinue RRT and have a look what happens. Or we could do it stepwise. We could do a change in the modality, the frequency, or the duration of the individual session or the treatment. For example, we could switch a patient from a continuous treatment to a prolonged intermittent and finally to an intermittent, and then gradually try and wean him. So there is different opportunities and possibilities, but the question, of course, is when do we try and have a look? So the guidelines are pretty unspecific. We should stop renal replacement therapy when it's not longer required. I thought so. Either because intrinsic kidney function has recovered so that it meets the patient needs, or, and that's another important point, and of course not quite often happens in ICUs all over the world, if renal replacement therapy is not any more consistent with the goals of treatment, then of course we need to stop. So this can't be something we continue if the rest of intensive care is not going to be continued. Now, we need to have an idea how the intrinsic kidney function of the patient has developed. And this poses a problem because, at least when we do intermittent treatment, we have those solutions of solute and fluid levels and the sawtooth pattern of even daily intermittent dialysis that prevent us from using any clearance equations. And then we can only use the interdialytic period to evaluate urine volumes, plasma markers, etc. And then we have to consider there is a rebound if we do intermittent treatment and we stop. In the following hours, there will be a rebound and an increase in certain serum markers. And then there's non-renal factors that will impact on, for example, serum urea levels, on creatinine levels, etc., etc. During CRRT, it might be easier, because after 48, 27 hours or so, 72 hours, then we will come into a steady state. And then we could observe if, given the same dose being administered during continuous renal replacement therapy, if then the patient gradually decreases his markers, then we can safely assume that there is some intrinsic renal function coming back. But there is a big caveat. The typical formulae we use for calculation of eGFR, they are not valid in such a scenario. Anyway, they're only validated in chronic renal insufficiency. So we need something better. And I would propose to use that tool that has been proposed by Dr. Chen and colleagues like 10 years ago, and that's the kinetic GFR. And here you have the initial plasma creatinine, you need the distribution volume of creatinine, the generation rate, and then you have the difference between consecutive measurements. That looks like a complex formula, but of course, as it is typical nowadays, we have easy online calculators which you can download to your phone. And this makes a lot of sense. I'll show you an example. So, this is a patient with AKI. This is consecutive days. He starts with a creatinine of about 1. He's oliguric, so the next day the creatinine will be 2 point something. The second day after, it will be 3, 3.5, 4, and so forth. If you use a clearance equation, a typical, so on the first day, this clearance equation will give you a number of about 50% eGFR. And the day after, it's still 30 ml per minute, and so on. But in reality, as the patient is oliguric, already on the first day, the residual clearance will be 10 or below, and that remains there. And in a patient who gradually then recovers, there would be the increase in the serum creatinine, but then it would be leveling off. And the typical formula you use, they would just show you an ongoing decrease of the clearance, which is not true, in fact, because you can see here, already at that stage, the patient starts gradually to recover kidney function. And you can also use this in a patient who's undergoing renal replacement therapy. Here is the patient with a high creatinine level increasing, and then we start CVVH. And then on consecutive days, we see the gradual decrease in the serum creatinine. Your clearance formula would give you some gradual increase of function of the extracorporeal system, but in reality, on this day when we start, it goes up, and then it stays the same if you don't change the dose. So this is a tool you could use, and you could not use, of course, the typical eGFR formula we use in the stable chronic patients. And that actually works. This is just one example. That's a retrospective analysis of over 13,000 patients from the MIMIC2 database, where they calculated the kinetic eGFR during the first 7 days. And this is sort of a heat map, you see. If you calculate a high kEGFR, your risk for dying or for requiring RRT is very low. And the lower the kEGFR is, the higher the risk for needing renal replacement therapy or for death. Now, when we think about doing an attempt of weaning the patient, what are the basic requirements? I think it's clear that the underlying clinical problem needs to be controlled. The patient needs to have stable hemodynamics. There needs to be a recurrence or an increase in diuresis. And there is also the need for absence of actual fluid overload. And finally, the patient needs to have stable electrolyte and acid-base homeostasis. And the importance of the urinary output cannot be overstated, because in many studies, unfortunately, all of them retrospective or observational, there's basically nothing prospective randomized in there. But all these studies show that the urine output is the safest and best predictor of successful weaning. And that's from the BEST kidney study, over 1,000 patients, 500 of them could be going to a weaning attempt. And this is a systematic review and meta-analysis of 5 studies. This is the receiver operating characteristics of the different studies. This is joining those 5 studies. And you can see here, we're about in the 0.7 range of predictive value of the urinary output alone. And we can carry on with this. Diuresis, but also the course of serum creatinine has been proved to be the best predictive markers for successful weaning from RRT in about 12, in a set of 12 markers that these studies observed. And the other way around is also true if you have patients who have an increase in the cumulative fluid balance, then this is a predictor of need for prolonged CRRT. However, if the daily urine output increases per 200 milliliter per day increase, you have a significant higher probability of successful weaning. We should now not make the miscalculation that, well, if it's that easy, we can give loop diuretics, stimulate diuresis, and then everything will be good. So this is a prospective randomized double-blind study from Holland, 72 patients who received furosemide or placebo after stopping CVVH. Yes, those patients with furosemide increased their urine volume, but that was not associated with a shorter duration of renal failure or more frequent renal recovery. So it doesn't work. Other interesting parameters are, of course, the creatinine excretion. So this is the daily urinary creatinine, which predicts fairly well the successful weaning from renal replacement therapy. And you could also use the daily urea excretion. You can see here also ROC curves of about 0.7, 0.8. It's more important than just looking at the serum levels. Look at the urinary parameters. And then you could also do in your patient a timed collection of urine and then calculate endogenous creatinine clearances, even if you have 6 hours or 12 hours. And this might predict short time, 7 days after stopping RRT, but also long-term successful weaning in those patients with an increase in the creatinine clearance. Now, what about for biomarkers? If you look in PubMed, and I did that earlier this week, there is more than 8,000 results if you given the string acute kidney injury and biomarkers. Is there anything which can guide us, can help us in the decision when to start an attempt from weaning? There is some data, but that's also, again, mostly prospective observational. And interesting, especially seems to be the cystatin C, because it's not related to muscle mass, it's not easily removed by dialysis procedures, so it is a marker which can probably be better used than the standard parameters. And there is also a slight signal for the NGAL, but of course urine output is very important here as well. And this is a study looking at a whole set of many different of those novel biomarkers. And at the end of the day, the urinary fatty acid binding protein was with a moderate signal of about 0.65, 67 to give you some indication if there is a successful weaning attempt. What we rather do than just measuring one of the novel biomarkers, we try to employ a functional test. I earlier told you that giving loop diuretics to stimulate diuresis and keep diuresis going is not really helping in a successful weaning. But to do a furosemide stress test and get an idea if the kidney can respond to that furosemide by producing more urine, that could give you an idea. You'll probably be familiar with the furosemide stress test. You look at the diuresis in the first 2 hours after giving a bolus of furosemide, 1 milligram per kilogram. If the patient is already on furosemide, you give 1.5. And if in the 2 hours after that, the urine volume is lower than 100 ml per hour, then there is a nearly 90% or 87% sensitivity and 84% specificity for the prediction of further worsening of kidney function and need for dialysis. And that is a better predictor for requirement of renal replacement therapy as a variety of these novel biomarkers. And actually, There is interesting data from this study, the FST trial, that was 160 patients with AKI, critically ill, and 44 had a positive furosemide stress test, produced more urine than 100 ml per hour in the first 2 hours. 118 had a negative stress test, and only 13% with a positive stress test eventually required acute dialysis, but 75% of patients with a negative FST had to go on dialysis later on. So this could be a helpful tool. If you're in doubt, should I try or not, you give the furosemide, measure the urine volume for 2 hours, and then you might get a better idea of how your patient might respond. So that's already my final slide, putting together all things I said to you. We need a patient who is stable, hemodynamically stable, hydration status stable, electrolyte stable, and acid-base status stable. Then we have various tools or various parameters to look at in our decision. That's either a spontaneous urine output of at least 500, some people say it should be at least 800, or alternatively the furosemide stress test is positive, or by, for example, timed urine collection, you find an endogenous creatinine clearance of greater than 10, or genetic EGFR of greater than 10, or the patient in stable situation on stable CVH dose has a decrease in serum creatinine, then you might actually attempt to wean and do a pause. But importantly, that diuretics do not improve the probability and the chances of your patient to be successfully weaned. That's it from me. Thank you for your attention.
Thank you, Professor, for this fantastic overview on this difficult topic. Questions from the audience? I have a question. At least in my unit, a relevant percentage of patients move from continuous to SLED to intermittent dialysis. This is the usual way of withdrawal of this therapy, or in other units is performed directly from continuous to no dialysis?
Well, if you have all the options available, you're a lucky guy, because in the majority of units this is not the case. They either have continuous machines or they do intermittent treatment or prolonged intermittent, but it's not often that, or not all units do have all the modalities in one place. So if you have it, it's great, because you can then do a downscaling of your intensity of treatment and then see how the patient responds. And once you're not continuous anymore, of course you will have a day to see what happens. Does the creatinine increase? Does the urine output increase in the 24 hours when he's without treatment? And that's, of course, the ideal way to try. That's why in my first slide I showed you there's more ways to stop, not only stop, but then to de-escalate your treatment. But unfortunately, I'm not sure we could ask if everyone has all options available. I would guess it's not the case. Does everyone have both intermittent and continuous and prolonged intermittent treatment available? Who does not?
Raise your hands.
Yeah, so, well, it's a relevant number, of course.
Yeah.
So.
Okay, more questions?
Thank you. Just for my understanding, the furosemide stress test, is that performed where the patient is still on the hemofiltration, or you pause hemofiltration and you perform the furosemide stress dose test?
Well, typically we do it the way Professor Fernández has said. We do downscaling of the therapy. We rarely do it when the patient is still on continuous. We go to intermittent, even prolonged intermittent, and then in the phase when he's off, we do the stress test. So that's the standard we do. But of course, you might try it even if you have not a strong negative balance on the machine, then it's, of course, difficult.
I have another question. Maybe there are no data, but there is some role for echography, the kidneys, planking area, to predict this the withdrawal.
Perfusion,
renal resistive index, pulsatility, whatever.
Yeah. Well, of course, if you do Doppler and there is no perfusion, significant, of course, it can't work.
You will have.
But sure. But I'm not aware of any data, and we do not do that routinely in the
we
in that
either,
decision.
but it was just a question. Okay, thank you very much.
Well, the final presentation is given by Dmytro Khadzhynov from Berlin, and he will maybe, hopefully, answering the remaining questions.
Thank you very much for the kind presentation. Dear ladies and gentlemen, dear colleagues, thank you very much for staying so late tonight. And I should be talking about the remaining questions. We have been talking about the prediction. We have been heard about the modality choice, when to start, how to prolong the filter patency and efficacy of the anticoagulation. We have been talking about the fluid management, feeding, when to stop, and recovery. And I have to speak about the remaining questions. And I thought when I got this question, oh boy, what should I be talking about? So the only thing I thought about is the invitation to speak about something which I am interested, and I only hope that my interest correlates with yours. So I keep you entertained. CO2 retention and renal failure are very frequent findings during IRDS. So, and if you are in Europe, and obviously not in France, or maybe in Australia, you will definitely treat those patients first with continuous renal replacement therapy, and most of the time using the regional citrate anticoagulation. As you've heard from Professor Jonckheer about the citrate metabolism, we use this as a source for bicarbonate and for buffering. And we adjust our blood to the dialysate flow as the mechanism how we react on the metabolic changes. And anticipating those changes, commercial available solutions already provide us with the reduced bicarbonate and reduced sodium, as we are normally provide citrate as a 3-sodium citrate. We know that we can treat the metabolic alkalosis with the adjustment of the blood to dialysis flow. And we know that happens, we normalize the metabolic acidosis by those patients in between of 12 to 24 hours. We need just time. And then it remains stable all the time. Oops, sorry. Can I go backwards? Yes. And now it remains stable all the time. But the question is, does one size fits all? Do all patients require the same bicarbonate? Because what does the healthy kidney, in case of CO2 retention, to maintain a normal pH? It retains the bicarbonate, right? And what do we do with the patient on a continuous renal replacement therapy? At least this is a normal practice in our center. We maintain a physiological bicarbonate concentration, regardless sometimes of the CO2 and pH. So can we do better? And this was not my question, but the question of a colleague of mine, Philipp Enghart, and he designed the prospective randomized control trial as a pilot trial with interventional group. He enclosed the RDS patient with CO2 retention and acute kidney injury treated with continuous renal replacement therapy. And his question was the clinical benefit of CO2 tailored target bicarbonate concentration during continuous kidney replacement therapy using the formula I've already mentioned. Participants were adult patients with RDS, with attempted lung protective ventilation, hypercapnia, moderate hypercapnia, and citrate-based CRRT. Exclusion criteria were, of course, ECMO, other, buffering, liver failure, and lactate acidosis as the risk factor for citrate accumulation. There was a study protocol, 1-to-1 randomization, both intervention and control group. We had the follow-up of 6 days, and we monitored bicarbonate. As you see, the groups were, this is the preliminary results I am allowed to show. So the study is not finished. The groups are small, but this is the proof of concept, more or less. So we have the groups which are fairly good spread in terms of characteristica, in terms of the ventilation and in terms of the blood gas analysis. And what we could reach is the significantly higher bicarbonate in the interventional group. It only reacted in the higher, but without any significance, PeCO2 levels, and the pH was similar in both groups. What concerns the ventilation, there was no difference in driving pressure, pretty high. The respiratory minute volume was lower in the interventional group, although not reaching significance. And the tidal volume was definitely lower, although still not reaching the significance, but it's a trend over. And the number of patients who were protectively ventilated were significantly higher in the intervention group. So the question was, can we do better? And if we take the median CO2 concentration of our patient in intervention group, we are coming up with 28 millimole of bicarbonate as a target. And we reached the 29, so the answer is yes, we can definitely do better. But the more important question is, should we do better? And this is a controversy. So I start with the first point, is that the acid-base consequences of RCR are often and falsely reduced to the bicarbonate generation by citrate metabolism. As you have heard from the previous speaker, circulating calcium citrate complexes lead to mild plasma acidification because they are always chelated, they are always bound on the calcium. Of course, if calcium is in the physiological concentration and having only one small negatively loaded part of the molecules. These complexes, however, are very rapidly metabolized in the systemic circulation. The acid-base impact of regional citrate anticoagulation is not limited to the effect of the citrate itself. Many citrate solutions have a high sodium content, so this net sodium administration tends to increase plasma SED, leading to plasma alkalization. This is arguable, but it is a theory, at least. So you may ask, what is the difference between this concept, what we approached, to the purely bicarbonate infusion? It would be a fair question. And this is the second controversy, the lack of the randomized control trials of administration of sodium bicarbonate for respiratory acidemia. And hypercapnic acidosis is well tolerated, a few adverse effects as long as tissue perfusion and oxygenation are maintained. We know that low tidal volume ventilation in LA or RDS associated with permissive hypercapnia and has beneficial effects so far. And the buffering of hypercapnic acidosis could worsen the acute lung injury. What we also know is the recent study concluded that alkali therapy for mixed respiratory and metabolic acidosis might be useful, but was based on the conflicting and not conclusive evidence. And the third controversy is that the acid-base adjustment during the regional citrate anticoagulation is only possible if the permeability of the membrane remains intact. Prothrombotic states like sepsis, COVID-19 often lead to membrane clogging, and this is basically the building of a protein cake on the surface of the membrane, thus reducing the permeability of the membrane, which is crucial for our protocols. And the prothrombotic states, during prothrombotic states, the permeability of the membrane is gradually attenuating, starting as soon as 24 hours after the therapy begin, shown here as an example on the COVID patient, but not only COVID patients tend to membrane clogging as well. Reduced filter permeability during regional citrate anticoagulation in continuous kidney therapy often cause citrate net overload with hypernatremia and consequent metabolic alkalosis because we are not able to reduce the amount of calcium citrate complexes we are infusing, and this comes with the natrium as well. And we have shown it as an example on the COVID patient. Here you can see that the only possible intervention would be the filter change. You can see on the slide that during the reduced filter permeability, the serum bicarbonate goes high, pH goes high, sodium goes high, and it's not responding to our per protocol adaptation of the blood to dialysis ratio flow, although it's significantly reduced. Those changes are completely away if we change the membrane, and they are all just, they disappear so far. So in the conclusion, I would like to say that CO2-tailored targeting levels of bicarbonate during regional citrate anticoagulation for the continuous renal replacement therapy are possible. I'm not happy about this sentence, but it's at least make it easier for us to provide a lung protective ventilation. Further studies are warranted to investigate this safety, the safety of this approach, and a special attention should be paid to avoid the citrate overload, especially in patients in thrombogenic state. I would like to thank for all of my colleagues for this work and for you and your attention. Thank you very much.
Well, thank you for that very good lecture. And is there questions? Still the very last question? Yes. Before you get the mic, I have one already. I found it interesting that you say you have this, you change the filter if you see alkalosis or hypernatremia. You have cutoff levels there when you do that?
Well, we don't, unfortunately. It's a very eminent-based decision of the physician. We see if there is a reaction on the change of our adjustment of the dialysis machine. There is no reaction in between of 3 to 6 hours. It's basically the shift of the nurses. If we don't see the reduction of the bicarbonate, then we probably change the filter. And of course, if the bicarbonate is over 30, usually we do it as well.
Go ahead, please.
Thank you for this very nice presentation. I'm not actually sure that the metabolization of citrate causes bicarbonates, produces bicarbonate, because if you go and look into the Krebs cycle, what you will produce is CO2, and you will cause actually CO2 will, through the Henderson-Hasselbalch equation, go to, will acidify actually the blood. So I don't think that is the mechanism through which citrate will cause an alkalification of the blood. I think it is due to the CVVH or the CRRT actually itself, because the citrate will move inside your blood as citrate 3-, but also as a strong acid, as citrate 2-, who comes from the citrate 3-. And so you'll be removing also citrate 2- with more hydrogen atoms, and so you will alkalify your blood. So that's, I think that's a more logical explanation than the bicarbonate, because if you look at basic reactions, there's no bicarbonate that comes out the Krebs cycle.
Well, I agree to disagree because as far as I understand, at least to the patient we have been looking at, the metabolic disarrangement, they were resolving after we changed the filter. So it might be not a CVVH, it might be just an interruption in the permeability of the membrane. So it's just an easy explanation for myself, but I'm not the biochemist. I mean, you probably have more expertise on this.
Another question?
Yes, thank you. Thank you very much for your lecture. Probably the explanation is the steward theory, because you have accumulation of sodium and increase the SID and explain the increasing of bicarbonate. Yes. I agree with you, it's not the explanation with the Krebs cycle. But other point, I think it's very important to be careful with the delta of pressure before and after the filter, because when you have occlusion, like you show in COVID patient, in my unit we have the same experience, and we ask to the nurse to be careful with the delta pressure, and we have a pressure increase, delta pressure increase more than 50, we change the set. And it's the best thing, the best way to avoid this side effect, I think.
Absolutely true. This is a very good point, but unfortunately, this is not that often that our nurses are taking care of the pressure differences. Yes, I know.